Hello once again, and welcome to another one of my USMLE Step 2 CK audio reviews from my UWORLD notes. Today we're going to be talking about renal in specific. This is a nice passive study method used to recall information that I personally have written down for myself, and it could benefit some of you out there who would like to just listen while you work out, while you're in the car. So this is a pretty long topic. Let's get right down to it. So renal for internal medicine, we're going to talk about acid-base balances. So the normal pH is a pH of 7.35 to 7.45. A normal PCO2 is going to be between 33 to 45 millimeters of mercury, and a normal bicarbonate is going to be between 22 to 28 milliequivalents. Now, the major extracellular buffer in the human bloodstream is going to be carbon dioxide and a bicarbonate buffer pair, so it's both of them. And that has a pK value of 6.1. Classically, the acid-base status of a buffer can be determined using that old Hasselbalch-Henderson equation with the three values, which are variables of pH, the acid, the conjugate base, which is that pH equals the pK plus log of something. So we shouldn't even worry about that. It's just too much of an equation to remember for the exam, at least in my opinion. So we'll just dive into appropriate compensations with the primary disorders, whether it be metabolic or whether it be respiratory. So let's start off with arterial blood gas interpretations of primary acid-base disorders. So like we said, the normal pH is 7.35 to 7.45. If it's below that, you have an acidosis. If it's above 7.45, you have an alkalosis. If you have an acidosis, then you want to measure bicarbonate or PaCO2. If the bicarbonate is less than 22 with an acidosis, with a low pH, then that's a metabolic acidosis. And the compensatory mechanism there is a respiratory alkalosis, which is going to decrease your PaCO2. However, if you have acidemia with a low pH and your PaCO2 is high, that's a respiratory acidosis. In a respiratory acidosis, the compensation is going to be delayed, and that's going to be a metabolic alkalosis. So in a metabolic alkalosis, the compensation is going to be a retention of bicarbonate. Let's say you have a pH that's alkalotic, so above 7.45. Next, you want to measure your PCO2. If the CO2 is low, meaning that if it's less than 35, that's a respiratory alkalosis. Again, the compensation for respiratory alkalosis is going to be delayed, and it's going to be a metabolic acidosis as a compensation. So in the acidosis, you're going to be dumping out a lot of bicarbonate. So your bicarbonate levels will be low as a compensation to respiratory alkalosis. However, if you have an alkalosis, meaning that you have a pH that's more than 7.45, then you want to check your bicarbonate levels. If your bicarbonates are going to be more than 28 milliequivalents, then that's a metabolic alkalosis. And the compensatory measure for a metabolic alkalosis will be a respiratory acidosis, where you're going to be retaining carbon dioxide. So both metabolic disorders are going to compensate quicker than respiratory problems. So respiratory acidosis and alkaloses are going to have delayed compensation with metabolic compensations, versus metabolic acid-base disturbances, the compensations are going to be quicker because it has to do with the lungs are the ones that are going to compensate for those metabolic problems. Okay, so acidemia by itself does not cause CNS depression, but it often has an underlying cause of an acidemia that results in lethargy and altered mental status. Examples would be like CO2 retention due to COPD, and that can cause CO2 narcosis, which is usually seen when the PCO2 is extremely high, more than 60. Or if there's an anion gap metabolic acidosis due to acute kidney injury, for instance, and that's due to unmeasured urea toxin retentions. In acute kidney injury, that can also be a cause of a non-anion gap metabolic acidosis, which will not cause altered mental statuses. Whereas if you have an increase in BUN, probably due to the breakdown of blood proteins, that's due to the GI bleeding that will not cause altered mental statuses. So metabolic acidosis. So metabolic acidosis can be high anion gap metabolic acidosis, and it could be non-ion gap metabolic acidosis. So let's talk about anion gap metabolic acidosis. So a high anion gap indicates that there's a presence of a non-chloride containing acid that contains inorganic and organic or exogenous anions. So the organic ones would be like your keto acids, lactate, organic ions. Inorganic acids would be your phosphate and your sulfates. Exogenous acids and ions could be your salicylates or ingested toxins, or it could be unidentified ions. Seizures cause anion gap metabolic acidosis, and that's usually due to an increase in lactic acid production in the muscles and a decrease in hepatic lactate uptake. So usually it resolves within an hour to maybe 2.5 hours, 3 hours. So you want to observe for 2 hours and repeat the test. If it's not resolved by then you want to look for other potential causes of a metabolic acidosis. So how would you work up a high anion gap metabolic acidosis? So if you have high anion gap metabolic acidosis, you want to find out what are the clues. Do they have drug ingestions, hypoperfusions to the area, renal failure, hyperglycemia? Is there an osmolar gap? So if they have a drug ingestion, look for salicylates as part of your anion gap metabolic acidosis, and that will cause early on respiratory alkalosis. That is a commonly tested topic. So for salicylate ingestion, remember at first they will get a respiratory alkalosis because of the hyperventilation involved, but then it becomes a anion gap metabolic acidosis, as well as INH. INH can cause anion gap metabolic acidosis, as well as iron supplements. Hypoperfusion is another cause of metabolic acidosis, and this is due to increase in serum lactic acid, and that causes lactic acidosis. Renal failure can also cause an acidosis by increasing the BUN, and then that causes uremia. Hyperglycemia can cause metabolic acidosis by retaining urine and serum ketones, causing a diabetic ketoacidosis. And finally, an osmolar gap will be caused by things such as ethylene glycol that will also cause urinary calcium oxalate crystals, methanol causing blindness, and propylene glycol. So what are some of the high anion gap metabolic acidosis that are common? So you have your mnemonic mud piles, methanol, uremia, diabetic ketoacidosis, propylene glycol or paraldehyde, INH or iron. You have your lactic acidosis, your ethylene glycol or your antifreeze, and salicylates like aspirin. So methanol or formaldehyde is a formic acid. Uremia is due to a non-osmolar gap, and that causes an impaired excretion of hydrogen ions. Diabetic ketoacidosis, due to those ketone bodies like beta-hydroxybutyrate and acetoacetate. Then your ethylene glycol, that's your glycolytic acid and oxalic acid. And then aspirin is going to cause that mixed anion gap metabolic acidosis due to the overproduction and underexcretion of organic acids. And then you have respiratory alkalosis, which activates the medullary respiratory center and causes tachypnea. There's no osmolar gap, such as salicylates, lactate, sucralfate, and phosphoric acid. And the mnemonic here is MACRA. So MACRA causes a metabolic acidosis and respiratory alkalosis. Okay, ethylene glycol poisoning or antifreeze. This is a metabolic acidosis with a pH of less than 7.35, and it's a primarily decreased in bicarbonate. So serum osmolarity is often obtained in patients with anion gap metabolic acidoses, and suspected ingestion is increased. the combination of increased anion gap and an increased osmolar gap will be caused by things such as methanol, ethylene glycol, or methanol poisoning. The osmolar gap is measured with serum osmolarity minus the calculated serum osmolarity. So a normal osmolar gap is going to be less than 10. Urine analysis will show for ethylene glycol rectangular envelope-shaped oxalate crystals, and the complications here would be acute renal failure. The urine anion gap is calculated when there is a normal anion gap metabolic acidosis, and the urine anion gap helps determine such an acidosis is due to either renal or intestinal bicarbonate losses. Renal losses of bicarbonate occur with renal tubular acidosis or carbonic anhydrase inhibitor use. And GI loss of bicarbonates occur classically in diarrhea. So what are some of the non-anion gaps metabolic acidosis? You have diarrhea. Fistulas can cause a normal anion gap metabolic acidosis, such as fistulas in the pancreas, ileocutaneous fistulas, etc. You have carbonic anhydrase inhibitors that can do it, renal tubular acidosis is in the name, and urethral diversions like an ileal loop or iatrogenic causes. Some causes of metabolic alkalosis, first of all, you would need to do a differential diagnosis of a metabolic alkalosis. So remember, a metabolic alkalosis means that your pH is going to be greater than 7.45 and your serum bicarbonate is going to be greater than 24 milliequivalents. So what do you do next? If you have a metabolic alkalosis, you want to check your chloride levels. If you have low chloride with alkalosis, then that's probably due to vomiting, GI loss, nasogastric aspiration, or prior to a diuretic use. And here, these patients respond to giving them normal saline. However, if your urine chloride is going to be high, then it's either due to hypovolemia, euvolemia, or a hypervolemia. So let's say you have a urine chloride that's high with a metabolic alkalosis, and they have hypervolemia. Why is that? It's because of either excess mineralocorticoid activity, because of primary hyperaldosteronism, or Cushing's disease, or an ectopic ACTH production. So there's excessive black licorice ingestion as well as a cause of a hypervolemic high urine chloride metabolic alkalosis. And again, these are not responsive to saline. So the high urine chloride diseases with metabolic alkaloses are not responsive with saline, versus the low urine chloride ones are responsive. But what if you have a high urine chloride and it's hypovolemic patient or a euvolemic patient? Then you want to see if they have current diuretic use or if they have Barter's or Gilman syndrome. If they are taking diuretics, then obviously they would be responsive to giving them normal saline. But if they have something called Barter's or Gilman syndrome, then saline isn't going to help because this is going to be a tubular issue. Clinical features of metabolic alkalosis, so causes would be saline responsive versus saline resistance, like we said. Saline responsive ones would be your vomiting, gastric suctioning, diuretics, laxative abuse, decreased oral fluid intake, like you have a volume depletion. Or you have ones that are resistant to saline. That means that giving them saline won't work, like primary hyperaldosteronism, Cushing's syndrome, or a severe hypokalemia, meaning that your potassium levels are less than 2. Clinically, they present with volume depletion, easy fatigability, postural dizziness, muscle cramps. They can have hypokalemia, so they'll have signs of muscle weakness and arrhythmias. Their urine chloride is going to be less than 20 milliequivalents. And if that's the case, then it's saline responsive. Whereas if their urine chloride is greater than 20 milliequivalents, then that's saline resistant. And the treatment here is to treat the underlying cause and then to just reverse the generation phase in all cases. If they're saline responsive, also give them normal saline to correct the maintenance phase. So if they are saline responsive, so recurrent vomiting, nasogastric suction, basically loss of body acid or hydrochloric acid, potassium chloride, fluids, sodium chloride, all these cause a loss of chloride, a loss of potassium, and a lack of acidity. So that'll lead to a decrease in excretion of bicarbonate from the liver and a decrease of excretion of bicarbonate from the pancreas. Because of that, you have a metabolic alkalosis and a generation phase. This will lead to a fluid depletion and activation of the Renin-Angiotensin System because there's a hypovolemic state, and this will lead to sodium and chloride and water retention and potassium and hydrogen losses. This is basically called a contraction alkalosis maintenance phase. There's a decrease in serum chloride, also is going to impair bicarbonate excretion, further worsening the metabolic alkalosis. So the treatment here is to give them fluids, to give them normal saline. The fluid correction is going to diminish the renin-angiotensin-aldosterone system effect, and it also corrects the hypokalemia with potassium supplementation. Saline responsive metabolic alkalosis is usually going to respond to isotonic saline infusion alone, and it could restore both extracellular fluid volume and low serum chloride levels. However, if there is no response to saline, that means that there's high aldosterone states. Remember, high aldosterone is going to cause sodium and water retention as well as potassium and hydrogen loss. I always like to think of that sodium is, wherever sodium is, potassium is in its opposite direction. So high aldosterone means high sodium means low potassium, and low potassium means alkalosis due to a hydrogen loss. Because of the water retention, you get hypervolemia, and this affects the kidneys, and it also affects sodium and chloride excretion. So you'll have a urinary chloride levels that are going to be more than 20 milliequivalents usually. And it usually does not respond to saline infusion alone, and then it also does require correction of the underlying disorder. So if the disorder is like a hyperaldosteronism, you're not going to correct it with just giving them fluids. You want to correct the hyperaldosteronism. Next up is respiratory alkalosis. So respiratory alkalosis, the causes here would be hyperventilation due to like a pneumonia or high altitude or salicylate intoxication. Have you ever been up in the mountains to go skiing or whatnot? When you're up there, you start, since the air is so thin, oxygen levels are so low, you start hyperventilating, and when you hyperventilate, you blow off a lot of carbon dioxide, and that leads to a respiratory alkalosis. Or salicylate intoxication acutely, like we said earlier. Hypocapnia is going to be a normal phenomenon of late pregnancy caused by direct stimulatory effect of progesterone on the central respiratory system. So because of the progesterone acts on the respiratory drive, that increases that respiratory drive, relative hyperventilation occurs, and you get a respiratory alkalosis, primary respiratory alkalosis. Now, renal tubular acidosis is going to be the next topic. It's a group of disorders characterized by non-anion gap metabolic acidosis in the presence of preserved kidney function. In renal tubular acidosis, you have type 1, type 2, and type 4. For some reason, they skipped type 3 for some reason. So type 1 is a distal problem. Type 2 is proximal. So to me, in my head, it's inversely proportional. So type 1 is going to be distant, type 2 is proximal. So type 1 or distal problem, the primary effect here is poor hydration secretion into the urine. Or not hydration, I'm sorry, poor hydrogen secretion into the urine. So you have a problem putting in hydrogen ions into your urine. So you're retaining a lot of that hydrogen ions. Your urine pH is going to be greater than 5.5 because it doesn't have the hydrogen ions. And your serum potassium levels are going to be low or normal. Causes of distal renal tubular acidosis or type 1 are going to be genetic disorders that affect the distal renal tubes. You have your medication toxicities, autoimmune disorders like Sjogren's syndrome and rheumatoid arthritis as well. Type 2 renal tubular acidosis is your proximal renal tubular acidosis, and it affects basically bicarbonate reabsorption. Here, the urine pH is going to be less than 5.5 because it doesn't have a problem reabsorbing hydrogen ions or excreting hydrogen ions. So hydrogen ions are going to get into your urine. So that's why the urine pH is low in type 2, but your bicarbonate levels will be also low because you have no reabsorption of bicarbonate. Also, serum potassium levels are going to be, again, low to normal, and causes of proximal renal tubular acidosis would be like your Fanconi syndrome, which causes glucosuria, phosphaturia, and amino aciduria. And then finally, type 4 is going to be an aldosterone resistant defect. So type 4 is going to be a urine pH is going to be low, less than 5.5, so it's more acidic. But however, the serum potassium levels in this one is high. And the causes of type 4 is an obstructive uropathy or a congenital adrenal hyperplasia. So as you can see, the differences here lie on the serum potassium. Serum potassiums are going to be lower normal in both type 1 and type 2, but it's going to be high in type 4. And the only one that has high urine pH is going to be type 1. All right, so a normal anion gap metabolic acidosis is going to cause renal or GI abnormalities, more likely. So all results in growth failures due to poor cellular growth and division in acidic mediums. Also, screening labs are going to show low serum bicarbonate levels and hyperchloremia, as well as a normal anion gap metabolic acidosis. The evaluation of a urine pH and urine electrolytes can help distinguish the different types of renal tubular acidoses. So let's recap this all over again. Type 1 renal tubular acidosis, again, is distal. It's a decrease in hydrogen excretion in the urine, causing alkalinization of the urine and no new bicarbonate generation. And that's going to lead to a metabolic acidosis. There's alkaline urine, which causes nephrolithiasis, so remember calcium stones from alkaline urine, as well as nephrocalcinosis. This can occur in sickle cell traits, and the diagnosis is to give them acid. When you give them acid, this is going to cause the urine to remain basic. And the treatment here for type 1 renal tubular acidosis, the distal, is to give them oral bicarbonate and to normalize the bicarbonate level. Now, type 2 renal tubular acidosis is your proximal renal tubular acidosis. It's an inability to absorb bicarbonate in the proximal tubule. This ultimately leads to all body bicarbonate loss, and the urine won't excrete any more bicarbonate, leading to urine and serum acidosis. The diagnosis here, how do you diagnose this, is to give them bicarbonate. When you give them bicarbonate, the urine is going to remain basic instead of preserving the bicarbonate. The treatment here is oral bicarbonate replacement and diuretics to decrease blood body volume. All right, and then finally you have your hyperkalemic renal tubular acidosis, as they say, or a type 4 renal tubular acidosis. This is an impaired function of the cortical collecting tubules due to aldosterone deficiencies or a resistance to aldosterone that causes a retention of hydrogen and potassium. Type 4 renal tubular acidosis is common in elderly patients with poorly controlled diabetes. This causes damage to the juxtaglomerular apparatus, and then that leads to a hyporeninemic hypoaldosteronism that then causes mild hyperkalemia, which is potassium levels between 5.2 to 6, and a mild acidosis, which is a bicarbonate levels between 15 to 20, on a background of preserved or moderately decreased glomerular filtration rate of 20 to 50 milliliters per minute. The hypertension may or may not be present, and it's usually due to accompanying atherosclerosis. So atherosclerosis is usually going to accompany this disease. Next up is electrolyte imbalances, such as hyperkalemia. So some of the causes of hyperkalemia would be most often due to a decrease in urinary potassium excretion. So acute kidney disease or chronic kidney disease can lead to hyperkalemic causes. So medication of disorders that impair the renin-angiotensin axis as well, and an increase in potassium movement outside of the cells like in an uncontrolled hyperglycemia or in a metabolic acidosis. This will cause potassium to move outside the cell, as well as an increase in tissue catabolism like traumas or tumor lysis syndrome, where the cell explodes and releases all its contents into the bloodstream, leading to hyperkalemia. So what are some of the medications that can cause hyperkalemia? So you have your non-selective beta-adrenergic blockers, and these interfere with the beta-2 mediated intracellular potassium intake. Angiotensin converting enzyme inhibitors or ACE inhibitors are going to inhibit angiotensin 2 formation with the subsequent decreases in the aldosterone secretion. Then you have your angiotensin 2 receptor blockers, or your ARBs, that block the angiotensin receptor, thus decreasing aldosterone secretion. You have your potassium sparing diuretics, which block the epithelial sodium channels or aldosterone receptors, as well as your cardiac glycosides like digoxin. And digoxin inhibits that sodium potassium ATPase pump. NSAIDs are going to impair local prostaglandin synthesis, reducing renin and the aldosterone secretion. Cyclosporines are going to block aldosterone activity. Heparin is going to block aldosterone production. And NSAIDs are going to decrease the renal perfusion, resulting in a decreased potassium delivery to the collecting ducts. And finally, succinylcholine is going to cause extracellular leakage of potassium through acetylcholine receptors. We have also trimethoprim that can cause hyperkalemia by blocking the epithelial sodium channel in the collecting tubule. And that's similar to the potassium-sparing diuretics like amiloride, and more common in HIV-infected patients being treated with high doses. But at normal doses, it can cause a modest increase. Serial monitoring is then going to be required in those patients being treated with high doses to avoid serious complications, and also competitively inhibits the renal tubular secretions of creatinine. That's going to lead to an artificially increased creatinine levels, although GFR is going to remain unchanged. So what are some of the clinical features of hyperkalemia? Well, you have EKG changes such as tall peaked T waves with short QT intervals. You have prolongations of the PR interval as well as QRS widening. And you also have disappearance of the P waves. And the conduction blocks as well, ectopic waves or sine wave patterns. The cardiac membrane stabilization can also be a feature of hyperkalemia. And here it would be due to a calcium infusion. And in the IV form, remember, calcium chloride or calcium gluconate will stabilize the cardiac membrane, making it resistant to the effects of hyperkalemia. So that's one of the treatments for hyperkalemia, calcium gluconate. Rapidly acting treatment options here would be insulin with glucose, beta-2 adrenergic agonists, and sodium bicarbonate. In the inhaled form, all these are, beta-2 adrenergic agonists are in the inhaled form, obviously, like albuterol. These are used in coronary artery disease patients, is dangerous as it can cause tachycardia and it can precipitate angina. So do not use albuterol in CAD patients. Then you have the removal of potassium from the body, slow acting. So diuretics can remove the potassium levels. Diuretics are contraindicated in dehydrated patients, obviously. Cation exchange resins and hemodialysis can all be a treatment of hyperkalemia. Intracellular shifts are usually transient, so the efforts to decrease total body potassium should still be made. And remember that hyperkalemia causes the tall peaked T waves on an EKG, loss of a P wave, prolonged PR interval, and a widened QRS complex with a sine wave pattern, as well as AV node blocks in the fascicle and beta bundle branch blocks. So patients with chronic hyperkalemia may be asymptomatic until the potassium gradually rises to more than 7 milliequivalents. Acutely, it can cause symptoms at lower levels, and patients can develop ascending muscle weakness with flaccid paralysis. The management here of hyperkalemia is to first do an EKG, exclude acute treatable causes of the hyperkalemia like uncontrolled hyperglycemia or a tumor lysis syndrome. You want to review any current medications the patient is taking, and if none of the above causes are found, then you want to do a urinalysis for differentiating renal from non-renal causes of hyperkalemia. You also want to evaluate for hyperaldosteronism with the renin-angiotensin and aldosterone levels. With renin levels and aldosterone levels, not the angiotensin system. Indications for emergent treatment of hyperkalemia would be a presence of a hyperkalemic related EKG change, or there could be a marked elevation of more than 6.5 milliequivalents without any characteristics of EKG changes, or it could be a rapid rise in the serum potassium levels that could be due to tissue breakdown, like we said. Hemodialysis is going to be best in patients that have renal failure. Diuretics are going to delay the excretion by approximately 30 minutes. Your sodium polyestrine sulfonate is a potassium binding resin that decreases total body potassium content, and sodium is exchanged for potassium in the gut. So that sodium is then exchanged, and the sodium polystyrene sulfate, that's going to take at least 1 to 2 hours to take effect. Hypokalemia, the causes of hypokalemia would be an increased potassium entry into the cells. How do they do that? With beta adrenergic activity, or exogenous or endogenous causes of beta adrenergic activity. That's going to stimulate sodium potassium ATPase pumps and the sodium potassium 2-chloride cotransporter pumps that shift potassium into the cell. It also promotes insulin release. So insulin is going to further shift that potassium into the cell, and the hematopoiesis is also going to shift potassium inside cells. So the more red blood cells you have, the more potassium are going to go inside those red blood cells. Renal potassium wasting, like hyperaldosteronism and diuretics, can cause renal wasting and hypokalemia, as well as GI losses like diarrhea, because the lower GI has increased potassium concentration. And then vomiting is going to lead to a metabolic alkalosis, and that's going to lead to a renal potassium wasting. And then finally, hypomagnesemia is notorious for causing refractory hypokalemia. So look for that chronic alcoholic in the vignette with altered electrolyte levels, and here you would want to give them magnesium, because if you give them potassium or you give them calcium or whatever the electrolyte is, magnesium is going to be required in order for those electrolytes to work. So chronic alcoholism causes low magnesium, it causes low potassium and low phosphate, and that low phosphate magnesium is an important cofactor for potassium uptake and the maintenance of intracellular potassium. So you want to check and correct magnesium levels in chronic alcoholics to correct the hypokalemia. Another cause of hypomagnesemia would be diuretics. All right, so now we're moving on to sodium. So here the topic is hypernatremia. So in hypernatremia, you want to assess volume status. Are they euvolemic or are they hypovolemic? If they're euvolemic, then you just want to do free water supplementation. If they're hypovolemic and then you want to ask yourself, are they symptomatic? If not, then you want to give them 5% dextrose in water. And if they are symptomatic, then you want to give normal saline until they're euvolemic. And then once they achieve euvolemia, you want to put them on 5% dextrose. So the most common cause of hypernatremia is hypovolemia. The causes of hypovolemia would be a increase in hypotonic fluid loss and a decrease access to free water, and that usually is in debilitated patients who do not have access to free water. So management of mild hypovolemic hypernatremia is to give them 5% dextrose in half normal saline. And if the hypovolemia is severe, causing hypernatremia, then initially you want to treat them with normal saline, 0.9% normal saline, and then gradually correct the hyperosmolarity while normalizing the patient's volume status. Isotonic saline is usually hypoosmolar in comparison to hypernatremic plasma. So once the volume deficit has been restored, those patients are then switched on over to half normal saline in order to just better replace the free water deficit. And the goal rate here of the plasma sodium correction is no more than 1 milliequivalent per liter per hour. And that is, it might not be an answer for a test question, but it will be in the test question, or it could be in the answer choices, but it's not the directed answer. the dosages, because dosages are not ever going to be part of the exam. But here's something that you'd probably want to remember is you don't want to correct sodium more than 1 milliequivalent per liter per hour without exceeding 12 milliequivalents per deciliter per 24 hours. So if a greater rate of correction happens, then that can result in cerebral edema, and colloids here are going to be of no more benefit than that of normal saline, and it gets more expensive. The management of euvolemia or hypervolemia hypernatremia is 5% dextrose and water in the treatment, and that's the treatment of choice. 5% dextrose is preferred over half normal saline anyway. So remember that you want to use 5% dextrose for non-symptomatic hypovolemia. And if they are symptomatic, you want to give normal saline until they become euvolemic and then switch them on over to 5% dextrose. But if 5% dextrose isn't in the answer choices, you can go from normal saline down to half normal saline. Moving on, we have hyponatremia. So this would be like a serum sodium level of less than 130. And this can lead to seizures in cases of severe hyponatremia. So it's a medical emergency that needs prompt correction with 3% saline. However, correction or serum sodium should not exceed 0.5 milliequivalents per liter to avoid causing that irreversible damage to the brain by osmotic demyelination, which we all know as central pontine myelinolysis. Rapid correction in the hyponatremia is going to cause fluid to move by osmosis from intracellular spaces, from neurons and the ganglia to extracellular spaces. And because it's now extracellular, it can disrupt the cellular metabolic activity and then lead to cell damage, specifically anosmotic demyelination. And the opposite can occur in hypernatremia, correction leading to cerebral edema. So how do we evaluate hyponatremia? So the evaluation of hyponatremia first starts off with a serum osmolarity level. If you want to check the serum osmolarity and you want to know if it's greater than 290 milliosmoles. If it is, then this is either due to marked hyperglycemia or an advanced renal failure. If it's not, then you want to check urine osmolarity. A urine osmolarity less than 100 means it's either primary polydipsia or malnutrition. There's one called beer potomania or beer drinking. But however, if the urine osmolarity is not less than 100, so it's greater than 100, and your serum osmolarity is not greater than 290, then you want to check urine sodium. If your urine sodium levels are less than 25, then that could be either due to volume depletion or CHF, or it could lead to cirrhosis. However, if the urine sodium is not less than 25, then that's SIADH, adrenal insufficiency, or hypothyroidism. So now we're going to see what are the causes of hyponatremia by the serum osmolarity levels and the extracellular volumes or the urine findings. So if the serum osmolarity is normal and there's no extracellular volume or urine findings, then the cause of the hyponatremia would be either a hyperproteinemic state or hyperlipidemia. If the serum osmolarity is very high, more than 295 milliosmoles, then those causes of hyponatremia would be due to hyperglycemia or exogenous solutes like radiocontrast dye or mannitol. However, if the serum osmolarity is low, less than 280, you got to find out if that's either due to a hypovolemic state, a euvolemic state, or a hypervolemic state. So if it's less than 280 milliosmoles with hypovolemia, then you want to check urine sodium levels. If the urine sodium is less than 10, then this is a non-renal salt loss like dehydration, vomiting, or diarrhea. But if the urine sodium is more than 20 milliequivalents, then it's due to renal salt wasting or salt loss, like in diuretics, ACE inhibitors, or mineralocorticoid deficiency. And that's a hypovolemic hyponatremia. Euvolemic hyponatremia can be differentiated if the urine sodium is more than 20, or if it's less than, if it's more than 20 with a urine osmolarity less than 300, or more than 20 with a urine osmolarity that's greater than 300. So if the urine osmolarity is less than 300, then it's the causes of hyponatremia would be a psychogenic polydipsia or beer potomania, or it could be if the urine sodium is more than 20, but the urine osmolarity is more than 300, then that's SIADH. And then finally, in your hypervolemic state, so a low osmolarity, less than 280, but hypervolemic state, here would be your congestive heart failure as causes of your hyponatremia, hepatic failure, or nephrotic syndrome. So what are some of the causes of hyponatremia? You have your hypovolemic hyponatremia, euvolemic hyponatremia, or hypervolemic hyponatremia. So I'm just repeating these over and over because they could be a little confusing. So in hypovolemic hyponatremia, this is due to volume depletion, so an acute blood loss, or it could be due to primary adrenal insufficiency, or it could be due to GI losses. Hypovolemia is going to increase renin-angiotensin aldosterone, and that's going to increase antidiuretic hormone, which is then going to correct the hypovolemia by increasing water reabsorption and causing hyponatremia until the hypovolemia is corrected. So here it's because of a dilutional effect. In a euvolemic hyponatremia, you have SIADH can be cause of a hyponatremia due to drugs or malignancy, a primary psychogenic polydipsia, and hypothyroidism. And finally, hypervolemic hyponatremia can be either caused by CHF, cirrhosis, or chronic kidney disease, or a nephrotic syndrome. So what is SIADH? SIADH, or syndrome of inappropriate antidiuretic hormone, can be caused by NSAIDs, and this is due to potentiating the action of antidiuretic hormone. So before entering the diagnosis of an SIADH, hypothyroidism and adrenal insufficiency should be ruled out. Then you want to calculate plasma and urine osmolarity simultaneously to make the final diagnosis. So how do you check for serum osmolarity? That's 2 times the sodium plus BUN divided by 2.8 plus glucose divided by 18. SIADH can occur in the presence of an underlying lung cancer. So findings seen in SIADH are going to be a serum osmolarity that's low, less than 270, and that's due to water retention from the antidiuresing hormone. A urine osmolarity more than 100 milliosmoles because of inappropriately elevated urine osmolarity, because there's no water going into that urine. It's just getting more concentrated. Urine sodium, again, is going to be more concentrated, higher than 20. There's also going to be an absence of hypovolemia because you're antidiuresing, you're holding in water. And normal serum creatinine, potassium, and acid-base balances, as well as normal adrenal and thyroid function. There's no obvious surgical, traumatic, or painful stimuli known to activate the neuroendocrine stress responses, and that includes ADH release. There's an absence of other known causes of hyponatremia, and in addition, when a normal saline bolus is given, the urine sodium excretion appears to increase while the serum sodium is relatively unaffected, indicating that the kidneys are continuing to inappropriately excrete sodium and retain water under the influence of antidiuretic hormone. There's going to be a low serum uric acid level because of a high excretion of urine into the causing the urine to be hemodiluted, and it's usually asymptomatic, or mild symptoms are seen until the serum sodium is less than 120 milliequivalent. So until it's below 120, then you start seeing symptoms. So again, remember, syndrome of inappropriate antidiuretic hormone means that you have too high levels of ADH, and when you have too much antidiuretic hormone, you tend to retain the water, and that's going to cause a dilutional effect. All right, and then you're not going to have any type of symptoms until it's diluted past the 120 milliequivalent mark. So the treatment of SIDH is going to be divided in between asymptomatic or mild symptoms, moderate symptoms, or severe symptoms. So what are some of the mild or asymptomatic symptoms? Be forgetfulness or unstable gait. Here, a fluid restriction of less than 800 milliliters per day with possible oral salt tablets and loop diuretics if the urine osmolarity is more than 2 times the serum osmolarity. The serum sodium should then be gradually corrected between 0.5 to 1 milliequivalent per liter per hour or 10 milliequivalents in 24 hours to prevent that osmotic demyelination syndrome. If they have moderate symptoms, that would be like confusion or lethargy, then you'd want to give hypertonic saline within the first 3 to 4 hours. That's to increase the sodium to more than 120 milliequivalents, and later you want to treat the same way as you would with mild hyponatremia. But if you have severe symptoms such as seizures or an inability to communicate or a coma, then obviously bolus or hypertonic saline until the symptoms resolve. Here you want to just forget about the whole central pontine myelinolysis adverse effect and just roll the dice, take your chances, because you want to preserve brain function. Bolus of hypertonic saline is then given with or without vasopressors like vasopressin receptor blockers like conivaptan, and this is going to be given IV. It's a renal ADH receptor blocker that's then going to cause selective water diuresis. It can be given alone or in combination with a bolus of hypertonic saline. So hypertonic saline is 3% sodium and has an electrolyte concentration of 1,025 milliosmoles per kilogram. Normal saline, remember, is 0.9%, so hypertonic is all the way to 3%, and has an electrolyte concentration of 300 milliosmoles only. That leads to a sodium chloride excretion that worsens the condition as the effect of the management of the SIDH requires the infused fluid to have a higher electrolyte concentration than the urine, not just that of the plasma. Next up is hypercalcemia. So hypercalcemia and increased or inappropriately normal PTH is going to cause either primary hyperparathyroidism or a familial hypocalciuric hypercalcemia. The difference here is that primary hyperparathyroidism has a high urinary calcium because of the excessive calcium mobilization from the bone, and in familial hypocalciuric hypercalcemia, there'll be a low urinary calcium, and this can occur due to a humoral hypercalcemia of malignancy due to a secretion of PTH-related protein. So familial hypocalciuric hypercalcemia is a benign autosomal dominant mutation in the calcium-sensing receptors. High levels of calcium are needed to suppress parathyroid hormone, and usually very low serum calcium, typically less than 100 per 24 hours, is given. Urine calcium can be more precisely calculated using the calcium creatinine ratios, which is a calcium in the urine divided by calcium in the serum, and that answer is divided by creatinine in the urine divided by creatinine in the serum. So a urine calcium creatinine clearance ratio is usually less than 0.01 in familial hypocalciuric hypercalcemia, compared to more than 0.02 in primary hyperparathyroidism. In familial hypocalciuric hypercalcemia, these patients are usually asymptomatic, and the potential complications here would be a pancreatitis or a chondrocalcinosis. So what is the management of hypercalcemia? Management is divided into severe symptoms, moderate, or asymptomatic. So severe would be a calcium levels that's greater than 14, or symptomatic hypercalcemia. So here the treatment would be divided into short-term or long-term. Short-term means immediate treatment, and that would be immediately treated with normal saline hydration plus calcitonin to bind that calcium and tone down the calcium, and avoid loop diuretics unless there's volume overload like in heart failure. Long-term treatment is with a bisphosphonate like zoledronic acid. And moderate hypercalcemia would be levels between 12 to 14. Usually no immediate treatment is required unless they're symptomatic if they have moderate hypercalcemia, and treatment is going to be similar to that of severe hypercalcemia with normal saline and calcitonin and with bisphosphonates as long-term treatment. And then finally, asymptomatic or mild symptoms with a calcium level of less than 12. There's no immediate treatment required, and you want to avoid thiazide diuretics. You also want to avoid lithium and volume depletion and prolonged bed rest. All those are to be avoided. So severe hypercalcemia symptoms are weakness, GI distress, your neuropsychiatric symptoms like confusion and stupor and coma, especially with a rapid rise in serum calcium. Polyuria from hypercalcemia induced nephrotic or nephrogenic diabetes insipidus, and a decrease in oral intake causing a volume depletion. That's severe hypercalcemia symptoms. Hemodialysis is then an effective treatment for hypercalcemia, but it's typically reserved for patients with renal insufficiency or heart failure whom aggressive hydration can't be administered safely. So just remember that whenever you have hypercalcemia, one of the first two things to go to for treatment is to give them IV hydration with normal saline. Unless they have CHF or renal insufficiency where you can't give them high volumes of fluids, then you want to consider hemodialysis, especially if they have renal failure. Next topic is causes of peripheral edema. So causes of peripheral edema are divided by their primary mechanism. So you have increased capillary hydrostatic pressure, you can have decreased capillary oncotic pressure or increased capillary permeability, as well as decreased capillary permeability, and lymphocytic obstructions, increased interstitial oncotic pressures. So let's go one by one. So increased capillary hydrostatic pressure, some clinical examples here would be like heart failure, and that would be like in your left ventricular or col pulmonale. Primary renal sodium retention can also cause increased capillary hydrostatic pressure, such as renal diseases and drugs that can cause renal sodium retention. And cirrhosis and venous insufficiency due to a venous obstruction can cause increased capillary hydrostatic pressure. And remember that the renal problem with the sodium retention is because there's a decrease in GFR, and that leads to volume overload, which occurs in nephrogenic syndrome and in end-stage renal disease. The next one would be a decrease in capillary oncotic pressure, or your hypoalbuminemia. This is due to protein loss, like in a nephrotic syndrome and a protein-losing enteropathy, as well as decreased albumin synthesis, like cirrhosis or malnutrition. Increased capillary permeability would be in cases like burns or trauma, sepsis. Allergic reactions can cause increased capillary permeability, acute respiratory distress syndrome, and malignant ascites. And then lymphocytic obstructions or increased interstitial oncotic pressure. This is due to malignancy, so you have a malignant ascites, hypothyroidism, and lymph node dissection. Now, casts in the urine. Casts in the urine could be either red blood cells, white blood cells, fatty casts, waxy casts, muddy brown casts. So muddy brown casts or granular casts, these are basically acute tubular necrosis problems. Red blood cell casts would be like a glomerulonephritis or a vasculitis. White blood cell casts would be due to an interstitial nephritis and a pyelonephritis, and it indicates that white blood cells are in the urine arising from the kidneys. Fatty casts are usually found in nephrotic syndrome, and brown and waxy casts are found in chronic renal failure. And that chronic renal failure is going to lead to broad casts that arise in dilated tubes of enlarged nephrons that have undergone compensatory hypertrophy. Remember, waxy casts are very shiny, like wax, and they're translucent. Hyaline casts, however, are in asymptomatic patients and patients with pre-renal azotemia. Most entirely, those casts are made out of proteins and they pass unchanged along the urinary tract. Moving along, we have urinary tract infections. So on dipstick, which are commercially available as in kits, those can detect the presence of leukocyte esterase and nitrates in the urine in patients with suspected UTIs. Leukocyte esterase is indicative of significant pyuria. Nitrates signify the presence of enterobacteria, which convert urinary nitrates into nitrites. And it's the most common cause of UTI by E. coli infection. So if you see nitrites in the urine, think E. coli. I also have a mnemonic for myself. The most common causes of UTIs is EPK. And order would be Enterococcuses or E. coli, P for Proteus, and K for Klebsiella. So whenever you see a UTI, I always go to those three, EPK, and whichever one is on the list first, that's the one I pick. High false positives and false negatives causes a negative test in suspected UTIs, and those should be confirmed with culture. So whenever you have a false positive, you have to confirm it with a culture regardless. Treatment of acute cystitis and pyelonephritis in non-pregnant women are divided into either complicated or uncomplicated cystitis or pyelonephritis. So in uncomplicated cystitis, the treatments here would be nitrofurantoin, and that's 5 days, and you want to avoid in suspected patients with pyelonephritis or with creatinine clearances that are low, less than 60 milliliters per minute. TMP-SMX for 3 days also can be used in uncomplicated cystitis, and that you want to avoid if there's a local resistance rate of more than 20%. Phosphomycin is another one for a single dose, as well as fluoroquinolones, and only if above options cannot be used. So basically, if phosphomycin can't be used, or TMP-SMX or nitrofurantoin, then you can give fluoroquinolones. Urine culture is needed only if initial treatment is going to fail. In complicated cystitis, fluoroquinolones are usually number one, and it's usually due to infections that have lasted more than a week to 2 weeks. So 5 to 14 days. So that's why it's complicated. So you want to give fluoroquinolones first. It's an extended spectrum antibiotics like ampicillin or gentamicin if it's even more severe. You want to also obtain samples of urine cultures prior to initiating the therapy, and an adjunct antibiotic as needed. For pyelonephritis can be either outpatient or inpatient. The outpatient would require fluoroquinolones at home, so ciprofloxacin and levofloxacin. Inpatients, however, require IV antibiotics. So here you would give fluoroquinolones, aminoglycosides with or without ampicillin. You also want to obtain samples for urine culture prior to initiating therapy and adjust the antibiotics as needed. Next, we have your glomerular and non-glomerular hematurias. So the type of hematuria in glomerular hematuria is microscopic, and common etiologies of glomerular hematuria would be glomerulonephritises, basement membrane disorders like Alport syndrome, and clinically they present with nonspecific or no symptoms at all. Nephrotic syndrome as well, such as hypertension and oliguria with elevated creatinine levels. On urine analysis, they can have blood and protein in the urine, as well as red blood cell counts, dysmorphic red blood cells, and that's about it. For non-glomerular hematuria, this is more gross hematuria, so a lot of it, with common etiologies including nephrolithiasis, cancers like renal cell cancer and prostate cancer, as well as polycystic kidney disease, and infections like cystitis or papillary necrosis and renal infarctions. Clinically, the presentation of a non-glomerular hematuria would be like dysuria or symptoms of urinary obstruction, flank pain, renal or ureteral colic, as well as anuria. And on urine analysis, there could be blood but no protein and normal appearing red blood cells. Non-glomerular causes of hematuria are basically more common than glomerular causes. Glomerular diseases are, so the differential diagnosis for glomerular diseases would be either mild glomerulonephritis, moderate to severe glomerulonephritis, or nephrotic syndrome. The definition of mild glomerulonephritis is that it's a nephritic urine sediment without any type of renal insufficiency or without nephrotic syndrome. The etiologies of mild glomerulonephritis would be like an IgA nephropathy or a lupus nephritis, as well as thin basement membrane disease. Then you have moderate to severe glomerulonephritis. These by definitions are nephritic urine sediments with a decrease in glomerular filtration rate and a variable proteinuria, and it can be in the nephrotic range. Etiologies for moderate to severe glomerulonephritis would be post-infectious glomerulonephritis, lupus nephritis, membranoproliferative glomerulonephritis, that tram track appearance, vasculitises like cryoglomerulonemia, and rapidly progressive glomerulonephritis. For nephrotic syndrome, the glomerular disease by definition would be that it's a bland urinary sediment proteinuria that's more than 3.5 grams in a day. It's possibly due to a microscopic hematuria. The etiologies for nephrotic syndrome here would be focal segmental glomerulonephritis or glomerulosclerosis. There could be minimal change disease, diabetes, lupus nephritis, as well as membranous nephropathy, IgA nephropathy, and primary amyloidosis. So the bland sediments are like few cells or casts that can present with significant edema as well as hyperlipidemia. Nephritic versus nephrotic syndromes are basically, the clinical features would be basically like edema, fatigue, proteinuria, and absence of hematuria, and hypoalbuminemia. That's found in nephrotic syndrome. Pediatric etiologies of nephrotic syndrome would be like minimal change disease, and adults would have focal segmental glomerulosclerosis or membranous nephropathy, as well as membranoproliferative glomerulonephritis, which is both a nephrotic and a nephritic syndrome. In nephritic syndrome, these clinical features will present with hypertension, oliguria, hematuria, proteinuria, and casts. The etiologies in the pediatric population would be post-strep glomerulonephritis, as well as hemolytic uremic syndrome. And in adults, IgA nephropathy can be caused by a nephritic syndrome, membranoproliferative, like we said, as well as, and also crescentic glomerulonephritis. Nephritic syndromes like Alport syndrome is a familial disorder. Alport syndrome presents in childhood as recurrent gross hematuria and proteinuria with sensorineural deafness. So here the mnemonic was can't see, can't pee, can't hear. Alternating areas of thickened and thinned capillary loops with splitting of the glomerular base membrane. Next topic, we're going to differentiate IgA nephropathy versus post-infectious glomerulonephritis. So in IgA nephropathy, this usually happens 5 days after an upper respiratory tract infection, versus post-infectious glomerulonephritis happens 10 to 21 days after an upper respiratory tract infection. This is one that they like to trip you up over, because you would think that post-infectious would happen immediately after, but it doesn't. It actually happens a week to 2 weeks or more afterwards, after the inciting event. So if it happens only within 5 days of an upper respiratory tract infection, like you got it on a Monday and suddenly now you're having symptoms on a Friday, then that's an IgA nephropathy. It's most common in young adult men, so age 20 to 30. That's another one that you should differentiate between IgA and post-infectious. IgA nephropathy is in 20 to 30-year-olds. Post-infectious glomerulonephropathy is more common in children, 6 to 10 years of age. So that's another good way of remembering it. In IgA nephropathy, it also causes recurrent gross hematuria. So both are going to present with gross hematuria, but the two ones that stand out clinically, and it's good for the exam, are that IgA nephropathy happens within a week, Post-infectious glomerulonephritis happens within 2 weeks, or 2 weeks, a week afterwards. So at least 10 days have passed by, then they'll start getting the symptoms. And also in IgA nephropathy, it happens in young men, 20 to 30 years of age, versus post-infectious glomerulonephritis happens in children, 6 to 10 years of age. The diagnosis for IgA nephropathy is through a normal serum complement levels, and there's also a mesangial IgA deposition seen on kidney biopsy. The prognosis for IgA nephropathy is usually benign, and it's possibly a rapidly progressive glomerulonephritis, or it can be a nephrotic syndrome with a worsening prognosis. Now, post-infectious glomerulonephritis, adults can be asymptomatic, or they can develop acute nephritic syndrome. They have low C3 complement levels, as well as elevated anti-streptolysin O antibodies or anti-DNase B antibodies. The kidney biopsy with the subendothelial humps consisting of the C3 component, that's the C3 deposition. So because of all those depositions, your complement levels are going to be low because they're all deposited in the basement membrane. The prognosis here is that children have a good prognosis, and possibly chronic kidney disease is found in adults if you have an adult with post-infectious. IgA nephropathy may also follow a GI infection, so that's another good point. And post-streptococcal glomerulonephritis can also occur after a streptococcal skin infection. So don't rule out skin infections for post-strep glomerulonephritis. Membranoproliferative glomerulonephritis is a nephrotic range proteinuria and hematuria. Type 2 membranoproliferative glomerulonephritis has dense deposits. So these dense intramembranous deposits, they stain for C3, and that's characteristic. And it's directed against C3 convertase of the alternative complement pathway. Because of that, it persists in complement activation, and then that's going to lead to kidney damage. Mixed essential cryoglobulinemia, the patients present with immune complex deposition in small blood vessels, and this is going to lead to an endothelial injury, leading to inflammation as well as end organ damage. Immune complexes are like IgM antibodies, similar to the ones seen in rheumatic fever, like rheumatoid factor, that form complexes with IgG anti-hepatitis C virus antibodies. So these IgM antibodies bind with IgG, or IgG binds to hepatitis C, and as well as hepatitis C virus RNA and complement. And it can be asymptomatic or develop signs of skin infections, palpable purpura. There can be Raynaud's phenomenon. In the kidney, you'll see membranoproliferative glomerulonephritis as an example. And in the nervous system, these signs would be like motor sensory exopathy or peripheral neuropathy. And musculoskeletal system, you'll see things like arthralgias or hepatosplenomegaly. You want to suspect mixed essential cryoglobulinemia if there's palpable purpura, hematuria, proteinuria, and the majority are going to have underlying hepatitis C virus infections. So look for that hepatitis C virus. If you have hepatitis C, then it's probably mixed essential cryoglobulinemia that they're getting at. The C in hepatitis C, remember, cryoglobulinemia. Diagnosis is serology. So serologically, you want to look for serum cryoglobulins and low complement levels, an increase in rheumatic factor and liver transaminases, or with kidney or skin biopsy. And you want to also see demonstration of circulating cryoglobulins, and that would be a confirmatory test. And the treatment for cryoglobulinemia would be to actually treat the underlying problem, which is the hepatitis C that's causing all that problem. So you want to treat that hepatitis C and to give them plasmapheresis to remove the cryoglobulins and immunosuppressants like steroids and cyclophosphamide. Next, we have thin basement membrane syndrome, and these basically present in adulthood with hematuria, but they don't have proteinuria, so it's just hematuria. And the biopsy is going to reveal markedly thin basement membrane. Pretty simple enough with thin basement membrane syndrome. Next up, we have nephrotic syndrome. And the primary causes of nephrotic syndrome are going to be either focal segmental glomerulosclerosis, membranous nephropathy, membranoproliferative glomerulonephritis, and minimal change disease, as well as IgA nephropathy. Now, the clinical associations with each is that in focal segmental glomerulosclerosis, this is associated with the African American population as well as Hispanics, obese people, HIV users, and heroin use. It's also known as HIV-related nephropathies, and it can be manifested even if HIV markers are negative. The next one, membranous nephropathy. This is a type of nephrotic syndrome that is associated with adenocarcinoma of the breast and the lung. It's the most common form of nephrotic syndrome in solid tumors, and knowledge helps screen for these tumors. NSAIDs, anti-inflammatory drugs, hepatitis B, and lupus as well are clinically associated with membranous nephropathy. Membranoproliferative glomerulonephritis is associated with hepatitis B and C, as well as lipodystrophy, and minimal change disease is associated with NSAIDs and lymphoma. Nephrotic syndrome usually resolves with successful treatment of that lymphoma. And then IgA nephropathy is due to upper respiratory tract infections. IgA-related glomerulonephritis with nephrotic range proteinuria are going to be focal segmental glomerulosclerosis, which are the most common, as well as membranous nephropathies, especially if they have contaminant hepatitis B infections or mesangial-proliferative and diffuse proliferative glomerulonephropathies. Nephrotic syndrome can also be divided into minimal change disease, focal glomerulosclerosis, or membranous glomerulonephritis. On histopathology, minimal change disease, there's nothing wrong there. It just looks normal. But the epidemiology with minimal change disease is the most common cause of pre-adolescent nephrotic syndrome. So if you see this in a pre-adolescent child, think of nephrotic syndrome, think of minimal change disease. Focal glomerulosclerosis has crescentic formations on histopathology. The epidemiology of focal glomerulosclerosis is most common cause in adults. And then finally, membranous glomerulonephritis shows up on histopathology with thickened basement membrane and subepithelial spikes. The epidemiology here of membranous glomerulonephritis would be that it's the second most common cause in adults. Complications of nephrotic syndrome is hypercoagulation. There's a risk of thromboembolic complications, and also multifactorial causes which increase urinary loss of antithrombin 3, altered levels of protein C and S, and increased platelet aggregation, as well as hyperfibrinogenemia, so high levels of fibrinogen, due to increased hepatic synthesis and impaired fibrinolysis. The veins are going to be more affected than the arteries. So renal vein thrombosis is the most common manifestation of coagulopathy with nephrotic syndrome, especially with membranous glomerulonephropathy. But arterial thromboses and pulmonary embolisms can also occur. Coagulopathy is going to be less common, but it's more severe in children as compared to adults with nephrotic syndrome. Renal vein thrombosis can present acutely with abdominal pain, fever, and hematuria, and it's more commonly progressive, causing gradual worsening or renal function of the renal function. So the renal function gets worse. Proteinuria in an asymptomatic patient is the most common presentation in membranous nephropathy than any other cause of nephrotic syndrome. So protein malnutrition, iron resistance, microcytic hypochromic anemia due to a transferrin loss. These are all complications of nephrotic syndrome. Vitamin D deficiency due to increased urinary excretion of cholecalciferol binding protein. There's, because that's a protein, right? Decreased thyroxine levels due to loss of thyroxine binding globulin, and increased susceptibilities to infections. All these are complications of nephrotic syndrome. So nephrotic syndrome, first of all, it starts off with a glomerular injury causing an increase in glomerular permeability. Because of that permeability in the glomerular basement membrane, this causes a leaking of protein into the urine, hence proteinuria. That proteinuria is going to cause low protein levels in the bloodstream, so a hypoproteinemia. Low levels of protein in the blood means that you have a low oncotic pressure, and because you have a low oncotic pressure, this can lead to both edema, which then causes hydrostatic pressure, and it could also cause hypovolemia, which causes an increase in aldosterone and increase in antidiuretic hormone secretion, which also stimulates sodium and water retention, leading to edema, as well as low blood flow to the kidneys. So the kidneys sense that there is no volume, obviously increases the Renin-Angiotensin System, causes vasoconstriction, causes an increase in hydrostatic pressure, which then leads to an edema. If we back up and we say that the patient has proteinuria, it means that they have low protein in the bloodstream, hypoproteinemia. That means that they'll have an increased synthesis of liver proteins and an increased synthesis in lipids. Because since you're losing all that in the urine, fatty casts, protein, then the liver is going to increase the production of lipids and it's going to increase the production of proteins. And this is going to lead to a hyperlipidemia. Increase in lipoproteins are going to hence be cholesterol and triglyceride synthesis, leading to an increased risk of atherosclerosis. And that atherosclerosis will then have you at risk of an MI or strokes, along with hypercoagulable states. This is aggressively treated with statins or other types of medications. Okay, moving on, membranous nephropathy. There's a strong association of membranous nephropathy with hepatitis B vaccination. Remember, hepatitis C was cryoglobulinemia. Hepatitis B is membranous nephropathy. So hepatitis B and vaccinations the hepatitis B vaccination decreases the risk here. The pathogenesis of membranous nephropathy or hepatitis B virus membranous nephropathy is depositions of the hepatitis B enveloped antigen or its corresponding antibodies in the glomerulus. So remember that E antigen, the enveloped. You mail an envelope, that means you're transmissible. That's going to deposit into the glomerular basement membrane, causing a membranous nephropathy. So the workup here would be a nephrotic syndrome in patients with hepatitis B endemic areas. So you want to screen for hepatitis B and you want to do a 24-hour urine sample. And that would give a protein excretion of more than 3 grams a day, and that's consistent with nephrotic syndrome. Serum C3 levels are typically low with hepatitis B virus membranous nephropathy, as well as anti-nuclear antibodies, which are seen elevated in lupus, and renal biopsy. So minimal change disease, the epidemiology here for minimal change disease is that it's the most common cause of nephrotic syndrome in children. The median age of minimal change disease is between 2 to 3 years of age, and 85% of cases occur before they're 10 years old. The pathogenesis of minimal change disease is that it's a T-cell mediated injury to the podocytes, causing increased molecular permeability to albumin. The majority of those cases are idiopathic, and features would be edema, fatigue, there's no hematuria, and the diagnosis is that you'll see proteinuria in the protein in the urine, so proteinuria, hypoalbuminemia, low protein in the bloodstream, and a renal biopsy will be without microscopic changes, so it'll look normal on renal biopsy when you look at it histologically. Treatment would be steroids. The confirmation of nephrotic range proteinuria is a 24-hour urine collection, although random levels can be used in appropriate clinical situations. The diagnosis of minimal change disease is going to be based on the age, so clinical presentation and response to steroids. Empiric steroid therapy should be initiated upon suspicion of the diagnosis, and approximately 85% of children will respond to their first steroid course. Renal biopsy is indicated in children that are ages greater than 10 with nephrotic syndrome, or in any child with nephrotic syndrome or minimal change disease that is unresponsive to steroids. Okay, next up we have amyloidosis. Now there's two types of amyloidosis. There's AL amyloid and AA amyloid. So AL amyloid is associated with multiple myeloma or with a Waldenstrom's macroglobulinemia. And its composition of amyloid is light chains. So AL, L for light chains, and it's usually lambda chains. So lambda is still with an L, light is with an L, AL amyloidosis. AA amyloidosis is due to chronic inflammatory conditions such as rheumatoid arthritis and inflammatory bowel disease. Also chronic infections like osteomyelitis and tuberculosis. The composition of the AA amyloid is going to be abnormally folded proteins. So you'll have your beta-2 microglobulin, that's an AA amyloid, as well as apolipoprotein or transthyretin. So an AA amyloid is shown in inflammatory amyloidosis versus AL amyloid is due to amyloid light chain amyloidosis. Amyloidosis can lead to enlargements of the kidney and in the liver. A renal biopsy would show amyloid depositions that stain Congo red and demonstrate a characteristic apple green birefringence under polarized light. These are all clue words here. Deposits are seen in glomerular basement membranes, and the blood vessels and the interstitium of the kidneys appear to be randomly arranged with thin fibrils on electron microscopy. Rheumatoid arthritis is going to be the most common cause of AA amyloid in the US. And then multiple myeloma is going to be the most common cause of AL amyloid. So remember the L in multiple myeloma is the AL of amyloidosis. Okay, moving on, we have diabetic nephropathies. Diabetic nephropathy is most common cause of end-stage renal disease in the U.S., and it occurs in 30 to 40% of patients, as well as 20% with type 1 and type 2 diabetes mellitus, or diabetic nephropathy, So risk factors for diabetic nephropathy are poor glycemic control, an increase in blood pressure, cigarette smoking, increasing in age and ethnicity. Examples would be like African Americans and the Mexican Americans have increased risk for diabetic nephropathy. Earliest renal abnormalities would be glomerular hyperfiltration injuries, and the first change that can be quantified is thickening of the glomerular basement membrane. Now, the most common histological findings would be diffuse glomerulosclerosis, but pathognomonic findings such as nodular glomerulosclerosis are common as well, with Kimmel-Still-Wilson nodules. Pathophysiology would be hyperglycemia that causes microvascular damage, or a microangiopathy, and the development of nephropathy is preceded by excessive protein excretion. The initial stages are termed microalbuminuria. Microalbuminuria is urine albumin excretion values that range between 30 to 300 milligrams in 24 hours. And the normal albumin secretion is going to be very low, less than 30 milligrams. So these patients have very high levels of albumin in their urine. Screening would be a spot urine collection, and it's timed urine collection for measurements of urine microalbumin to a creatinine ratio. And a good screening method for microalbuminuria is that creatinine ratio. 24-hour urine collection is slightly more accurate, but it's not preferred because of the inconvenience of having to collect urine all day long. Dipsticks can detect only macroalbuminuria, such as if they have more than 300 milligrams in 24 hours, but it's not recommended in the initial stages. The disease progression can be slowed by strict glycemic control and treatment of hypertension and angiotensin, the angiotensin blockers. So ACE inhibitors would be a good treatment for the hypertension and diabetic nephropathies. Diabetic autonomic neuropathy is responsible for outflow incontinence, but not diabetic nephropathy. Clinical clues suggesting albuminuria is due to non-diabetic renal diseases include onset of proteinuria less than 5 years after the start of the disease, and active urine sediments like red blood cell casts, cellular casts, and more than 30% reductions of GFR within 2 to 3 months of starting an ACE inhibitor or an ARB. The urine dipstick for proteinuria or albumin is either trace, 1+, 2+, 3+, 4+. If you ever see these, trace albumin would be between 15 to 30 milligrams per deciliter. 1+ protein would be between 30 to 100 milligrams. 2+ would be between 100 to 300. 3+ would be between 300 to 1,000, and 4+ would be more than 1,000 milligrams of albumin in the urine. And we said earlier that it should be less than 30, so less than 1+ is normal. So trace, it would be normal. But still, you don't want to see any type of albumin or protein in the urine. Hypertensive nephropathy. Hypertension is the second leading cause of end-stage renal disease, and hypertension mainly is going to affect the renal vasculature. Atherosclerotic lesions of the afferent and efferent arterioles and the glomerular capillary tufts is the most common renal vascular lesion. As the hypertension progresses, this causes renal blood flow and the glomerular filtration rate to decrease, and a sequence of kidney damage starts evolving from nephrosclerosis to glomerulosclerosis. Nephrosclerosis would be hypertrophy and intimal medial fibrosis of the renal arteries, versus glomerulosclerosis would be a progressive loss of the glomerular capillary surface area with glomerular and peritubular fibrosis. So it's just high flow of blood causing injury, causing fibrosis. Then a microscopic hematuria and proteinuria can occur due to the damage of the glomerular basement membrane, and then the kidneys start decreasing in size because they're just not getting good blood flow. Renal artery stenosis is a common finding in older patients. There's a high prevalence in those with severe hypertension or peripheral artery disease. Most hypertensive patients have essential hypertension, but renal vascular hypertension, as in the Renin-Angiotensin System, activates renin. It's the most common treatable cause of secondary hypertension and should be suspected in patients that have resistant hypertension or a diffuse atherosclerosis. The management of patients with renal artery stenosis and renal vascular hypertension is to manage with aggressive risk factor reductions. So you want to give them aspirin, you want to give them optimal diabetic control and with hyperlipidemia control, as well as smoking cessation to prevent cardiovascular diseases. Patients with hypertension should be initially managed first right off the bat with ACE inhibitors or ARBs. This is going to dilate the glomerular efferent arterioles, and additional antihypertensives can be used to optimally decrease the blood pressure control. In unilateral, stenotic kidneys experience decrease in renal blood flow and they have a decrease in GFR. So unilateral kidneys are unaffected kidneys, compensates the GFR, and it's no longer under the effect of the angiotensin II mediated renal vascular constriction, versus in bilateral renal artery stenosis, a fall in the GFR can lead to high creatinine, which is acceptable if there's an increase of less than 30%. Sometimes clearances in such settings, but still can be used with close renal function. You also want to monitor them due to long-term nephroprotective effects. Renal artery stenting or surgical revascularization is going to be reserved for patients with resistant hypertension or recurrent flash pulmonary edema and or refractory heart failure due to severe hypertension. So what are some of the clinical clues to renal vascular diseases? So you either have hypertension related symptoms or supportive evidence. So hypertensive related symptoms would be a resistance of hypertension due to an uncontrolled 3-drug regimen. Also malignant hypertension with end organ damage, an onset of severe hypertension, so they start off with more than 180 over 120 after the age of 55. These are all hypertensive related symptoms. Severe hypertension with diffuse atherosclerosis, and recurrent flash pulmonary edema with severe hypertension. These can all be hypertensive related symptoms to renal vascular diseases. Supportive evidence would be on physical exam. You'll see an asymmetric renal size, more than 1.5 centimeters. One kidney will be bigger than the other, blatantly. There would be an abdominal bruit as well. Laboratory results would be unexplained rises in serum creatinine more than 30% after starting ACE inhibitors or ARBs, and image results in unexplained atrophic kidneys. All right, next topic is going to be kidney stones. Causes of kidney stone invisibility on conventional radiographs. So radiolucent stones are your uric acid stones and your xanthine stones. Remember uric acid for lucent, uric, lucent. So yeah, I kind of remember it. Calcium stones are less than 1 to 3 millimeters in diameter. Non-stone ureteral obstructions would be like your blood clots and tumors. Calcium stones are going to be the most seen in patients with calcium stones, like hypercalciuria. So 24-hour urinary calcium excretions are greater than 4 milligrams in the urine. Calcium oxalate stones, these are the majority of kidney stones. They're 75 to 90% of stones are calcium oxalate. They're envelope shaped and seen on microscopic examination. They're also radio opaque. Calcium oxalate stones in Crohn's disease. Crohn's disease is a small bowel disease. It requires surgical resection, chronic diarrhea, or other small intestinal disorders. So these are going to cause fat malabsorption. So Crohn's disease, small bowel disease, surgical resection, all those cause fat malabsorption. This is going to lead to calcium that binds to fat in the gut, because normally calcium binds to oxalate and causes its excretion, but then oxalate unbound and free is going to go and absorb in the bloodstream, bound to that calcium. There's an increased excretion of oxalate by the kidneys, and then causing nephrolithiasis. Impaired fat absorption also impairs the bowel salt absorption, and that damages the colonic mucosa, causing an increase in oxalate absorption. Next, calcium phosphate stones. These are common in primary hyperparathyroidism and in renal tubular acidosis. Uric acid stones risk factors are an acidic urine. So it may be due to a defect in renal ammonia excretion or an increase in cell turnover that leads to a hyperuricemia, as well as hyperuricosuria and dehydration. Radiolucent stones are your uric acid stones, but can often be seen on ultrasound or on CT. How do you treat these patients is with hydration, alkalinization of the urine, alkalinized urine to around a pH of 6.6 to 6.5 with oral potassium citrate, as well as uric acid stones are highly soluble in alkaline urine. Citrate is also a stone inhibitor, and it reduces crystallization. A low purine diet can also be a treatment for uric acid stones, as well as allopurinol. That's an added benefit if there's recurrent stones despite above measures, and especially if the hyperuricosuria and hyperuricemia develop. Cystine stones are a group of disorders that are characterized by impaired amino acid transport. Several modes of inheritance and family history may be positive. There's a defective transport of amino acids, cysteine, lysine, arginine, and orthonine, by the brush border of the renal tubulars and the intestinal epithelial cells. That's going to increase urinary excretion. Cysteine is poorly soluble in water, and it's hard, radiopaque, hexagonal renal stones. So it's a positive urine nitroprusside test that detects high levels of urinary cysteine, and it's used as a qualitative screening procedure and helps confirm the diagnosis, especially in homozygotic individuals. Struvite stones occur when urine is alkaline because of the infection with urase-producing bacteria like proteases and with a history of recurrent UTIs. Obstructive uropathy can cause flank pain, the renal capsule distension, and poor urine output, such as a mechanical obstruction to the urine outflow. Intermittent episodes of high volume urine can occur when their obstruction is overcome by large volumes of retained urine, and that's a post-obstructive diuresis. This causes excessive diuresis and potassium wasting, as well as dehydration and weakness. Post-obstructive diuresis can occur in patients with bilateral or unilateral functional kidneys, as affected kidneys will produce large amounts of urine. However, chances of acute kidney failure are more in patients with unilateral functional kidneys. Next is the management of nephrolithiasis. So it's important concepts in the management of nephrolithiasis are going to include ultrasound, CT without contrast, that's better than plain abdominal x-rays, or a KUB in detecting radiolucent stones. Ultrasound is going to be preferred in patients with a low likelihood of other diagnoses in pregnant patients. Narcotics versus NSAIDs. If the kidney has normal function, then NSAIDs are going to be preferred, as narcotics can exacerbate nausea and vomiting. And the stones are going to be less than 5 millimeters in size, and that usually passes spontaneously with conservative management. Adequate hydration is going to be around 2 liters per day, and that increases urine flow and lowers solute concentrations. A detailed metabolic evaluation is not needed when a patient presents for the first time with a stone, but recurrent stones will require evaluations for up to 24 hours with a urine collection and measurement of calcium, measuring citrate, creatinine, and uric acid, as well as oxalate, pH, and sodium levels. So let's say you have a patient with a symptomatic urethral stone. Then you want to ask, is there urosepsis, acute renal failure, or a complete obstruction? If any of these are yes, then you have to do a urology consult. So if that's not the case, then you want to find out how big is the stone. If it's less than 10 millimeters or more than 10 millimeters. If it's more than 10 millimeters, call your urology consult. But if it's less than 10 millimeters, then you can do medical management with hydration, pain control, alpha blockers, and strains in urine. And then uncontrolled pain, and if the stone doesn't pass within 4 to 6 weeks, then you want to do a urology consult. And remember that alpha receptors are found on the distal ureter and the base of the detrusor, the bladder neck, and the urethra. So by giving them an alpha blocker, you get urethral relaxation, and that stone can pass easily. All right, moving on, we have prevention of recurrent nephrolithiasis. So you have dietary measures and drug therapy. So for recurrent nephrolithiasis, dietary measures include increasing fluids to produce more than 2 liters of urine a day. Also, you want to reduce sodium levels, so less than 100 milliequivalents. Remember that low sodium intake is going to increase sodium and calcium reabsorption via medullary concentration. So the medullary concentration gradient involving the calcium sensing receptors and the thick ascending limb or loop of Henle. If the patient continues to develop recurrent stones, then urine sodium concentration can be tested to check the adherence to sodium restricted diets. So you also want to reduce protein, also a normal calcium intake, which is 1200 milligrams a day. You want to increase citrate in your diet, so fruits and vegetables should be increased. Reduced oxalate diet for oxalate stones, so dark roughage and vitamin C. So you also want to decrease the intake of oxalate-rich foods like chocolates, teas, peanuts. Those can all cause recurrences of nephrolithiasis. And for drug therapy prevention, thiazide diuretics like amiloride, urine alkalinization for like potassium citrate or bicarbonate salts, as well as allopurinol for hypercosuric related stones. Kidney stones can cause ileuses, which resolve with treatment of the urolithiasis, and the ileus occurs in such a case that it's due to a vagal reaction. But you want to perform CTs of the abdomen if the ileus occurs to rule out any other types of causes. All right, moving on, we have urinary retention. So certain drugs like anticholinergics, antipsychotics, TCAs, they have anticholinergic properties. Sedative hypnotics, post-op urinary retentions, like bladder distensions during general anesthesia and epidural anesthesia, all increase the risk of urinary retention. So the urinary retention increases with advanced age. High fluid intakes during surgery and concomitant uses of other medications can cause urinary retentions by blocking parasympathetic pathways. This will then decrease the detrusor contractions and decrease internal sphincter relaxation, causing oliguria, which is defined as less than 250 milliliters of urine in 12 hours, or less than 0.5 milliliters per kilogram per hour. Or it could be less than 400 cc's a day or less than 6 cc's per kilogram per day. And this all can lead to an acute kidney injury. Midline suprapubic fullness and tenderness, as well as bladder distension, can cause constipation as well. An urgent urinary catheterization should be performed. A bedside ultrasound or a bladder scan, if available, can confirm the diagnosis, but you shouldn't delay catheterization. First step in any patient with recent oliguria is to change the urinary catheter and ensure that it's not clogged. It's cheap and effective. So remember Golgin's philosophy on things. Whatever's cheap is most likely the answer. All right, document post-residual volumes of more than 50 milliliters to provide symptomatic relief and discontinue the causative medications. Also, severe pain in patients with mild urinary obstructions, such as in a BPH, can cause urinary retention due to the inability to Valsalva because they're just afraid of having more pain. So what is the management of an acute oliguria? So let's do this little algorithm here. So first of all, you do a history and physical exam to assess for a BPH hyperplasia, benign prostatic hyperplasia. A bedside bladder scan is going to be used next to assess for urinary retention. And that's going to basically tell you, is there significant urinary retention or is there not significant urinary retention? If there is significant urinary retention with a bedside bladder scan, then you want to do a urethral catheter to decompress the bladder. Then a serum and urine biochemistry is done with or without imaging, and then you want to treat the underlying cause, whether it be BPH or malignancy, with a urological consultation. Now, let's say you back it up, you did the bedside bladder scan to assess for the urinary retention. There isn't any significant urinary retention, so why the oliguria? You want to check serum urine biochemistries with imaging or without imaging. So if it's a pre-renal cause or if it's a renal cause, if it's a pre-renal cause, then it's either due to hypovolemia, that's why you're getting the oliguria, or sepsis, or a low cardiac output, you're not getting enough volume to the kidneys. Then at that point, you want to give them fluids and appropriately treat them for the underlying cause of their oliguria. But if you find out that they are having oliguria due to renal causes, those renal causes can be like acute tubular necrosis or interstitial nephritis, as well as glomerular diseases. So at that point, you want to treat the underlying cause as well. If urinary catheterization does not relieve the oliguria, or if there's no significance in urinary retention, then acute kidney injury may be due to other reasons, like intrinsic reasons or pre-renal reasons, like we said earlier. Urinary incontinence. So what are some of the causes of urinary incontinence in the elderly population? So that could be genital urinary causes, could be neurological causes, and potentially reversible causes as well. So genital urinary causes of incontinence in the elderly could be either due to a decrease in detrusor contractility or overactivity of the detrusor. It could be due to bladder or urethral obstructions like a tumor or BPH. It could be due to a urethral sphincter or pelvic floor weakness, or because of a urogenital fistula. Neurological causes of incontinence in the elderly can be due to multiple sclerosis, dementia like Parkinson's, Alzheimer's, or normal pressure hydrocephalus, as well as spinal cord injury and disc herniation. Now, reversible causes of incontinence in the elderly could be like delirium, infection such as UTIs, atrophic urethritis or vaginitis, pharmacological causes like alpha blockers or diuretics, psychosocial causes like depression. There could be excessive urinary output like in diabetes mellitus or CHF, and a restrictive mobility such as if the patient's post-surgery, or stool impactation. So all these lead to a mnemonic called DIAPPERS, DIAPPERS. D for delirium, and I for infection, A for atrophic urethritis, P for pharmacology or pharmaceuticals, also P for psychosocial or psychological causes, E for excessive urinary output, R for restricted mobility, and S for stool impactation. Also alcohol as well. And now urinary incontinence, there's different types of urinary incontinence. You have stress incontinence, urge incontinence, and overflow incontinence. So the symptoms of stress incontinence would be leakage with coughing, sneezing, laughing, or lifting a heavy object. If you get a vignette with any of those scenarios, you want to treat with lifestyle modifications, pelvic floor exercises, pessary placements or Kegel exercises, and pelvic floor surgeries. If it's urge incontinence, then they'll describe a sudden, overwhelming, or frequent need to empty the bladder. They needed to go right now. They ran to the bathroom, so it just happened right now. So that treatment would be lifestyle modifications, bladder training, and antimuscarinic drugs like oxybutynin. And then you finally have overflow incontinence, and these patients present with constant involuntary dribbling of their urine. They're constantly leaking urine, and they don't have complete emptying, so incomplete bladder voiding. And here the treatment would be a cholinergic agonist like bethanechol. Remember the mnemonic, call Bethany to stimulate your bowels and bladder. So bethanechol, those are your cholinergic agents. And then intermittent catheterizations for chronic retention. So what are some of the differential diagnoses of urinary incontinence based on the type? So in stress incontinence, remember we said that that's a loss of a urethral support. Intra-abdominal pressure is going to exceed the urethral sphincter pressure. That's why it happens when they're leaking, or that's when it happens when they're coughing, sneezing, laughing, or lifting weights. They got that over exertional pressure that exceeds the urethral sphincter pressure, and that's what happens. In urge, you have the detrusor overactivity, like we said, that's a sudden, overwhelming, or frequent need to empty the bladder. And in overflow incontinence, it's constant involuntary dribbling of urine and incomplete bladder emptying because of an impaired detrusor contractility or a bladder outlet obstruction. So how would you evaluate incontinence? Incontinence should include, the evaluation should include urinalysis, urine culture, to exclude UTIs first and other reversible causes, especially if the onset is acute and in the elderly. Elderlies usually don't present with typical signs of UTIs, so that's a hint of urinary incontinence in the elderly. Measurement of post-void residual may be considered to rule out overflow incontinence. So you need to measure that post-void residual, and that should be less than 150 in women and less than 50 in men. In men more than 65 years age, it can be less than 100 due to slowing of their normal voiding mechanisms. In stress incontinence, this occurs in the association with obesity, with pregnancy, multiparity, and pelvic surgery, as well as menopause. Pelvic floor muscles form a U-shaped sling around the pelvic viscera and holds the bladder and the urethra to the appropriate anatomical position. Injury to those pelvic floor muscles is going to require causes a urethral hypermobility and a urethral prolapse out of the pelvis. And the bladder may also prolapse like an cystocele, causing a vaginal bulge. The diagnosis here would be that Q-tip test. Have you ever seen that? You place the patient in the dorsal lithotomy position, and then you insert a cotton swab into the urethral orifice. And the angle is going to be more than 30 degrees from horizontal when they have increasing in intra-abdominal pressure, and that signifies a urethral hypermobility. So you basically ask them to Valsalva with the Q-tip in the urethral orifice, and if it moves more than 30 degrees, that's significant hypermobility. Urine analysis and post-void residual volume should be normal, so less than 150 milliliters in women and less than 50 milliliters in men. And another type of urinary incontinence or stress incontinence results from intermittent urethral sphincter deficiency. And the treatment here would be an injectable bulking agent that increases the pressure at the bladder neck, and that will then decrease urine loss in patients with internal urethral sphincter deficiencies. This treatment isn't for urethral hypermobility. It's for stress incontinence. Urge incontinence is the result of a detrusor inactivity. So the detrusor muscle just doesn't work. Risk factors here are females that are over 40 years of age, and if they've had any type of pelvic surgery. Symptoms will occur throughout the day and are not related to the events that increase the intra-abdominal pressure. This is an urge incontinence. So treatment here would be to have pelvic floor exercises and to train the bladder. This will cause this is the initial management. The bladder training basically involves resisting the urge to void for progressively longer periods to increase the bladder capacity. So reducing the consumption of alcohol, of caffeine drinks like coffee, and caffeinated drinks like green tea and such, or carbonated beverages are recommended. If there's no response, then you can move on to doing pharmacological therapy. And the signs of urge incontinence is going to be exacerbated by a pessary. All right, moving along, we have interstitial cystitis. Interstitial cystitis means that the patient has a painful bladder syndrome. So what is the epidemiology behind this? It's more common in women, and it's associated with psychiatric disorders. The anxiety and the pain syndrome is like your fibromyalgia. Clinically, they present with bladder pain with filling, and then they get relief when voiding. And there's an increased frequency and urgency as well as dyspareunia. So think about interstitial cystitis kind of like irritable bowel syndrome, where you have relief when you defecate. Here you have relief when you void, I guess, something like that. Also, it's worsened by exercise and by alcohol consumption. The diagnosis here is a bladder pain with no other attributable causes that last for more than 6 weeks in duration, and the urinalysis is normal. There's no cure, so treatment focuses on the quality of life, behavioral modifications, and trigger avoidances. You can give them amitriptyline or analgesics for the exacerbations. Remember TCAs, amitriptyline, they're more commonly used for pain. So tricyclic antidepressants should now be called tricyclic analgesics. That's a little joke. Symptoms onset is gradual and worsen over periods of months, and diagnosis is mainly clinical. So next topic is crystal-induced nephropathy. So common etiologies of crystal-induced nephropathy that can lead to acute kidney injury would be if they're taking acyclovir, sulfonamides, methotrexate, ethylene glycol, or protease inhibitors. These can all cause acute kidney injury. Clinically, they present usually asymptomatic with an elevated creatinine within just a week of starting a drug. So if they've started any of those drugs within a week and they're having acute kidney injury, that's how they present. So it's on labs. Urinalysis can show hematuria, pyuria, and crystals in the urine, with an increased risk of underlying volume depletion as well as chronic kidney disease. and these crystals are seen under polarized light. Treatment for crystal-induced nephropathy is discontinuation of the drug, volume repletion, and to have concurrent volume repletion while giving the drug will prevent the kidney injury in the future. So stopping the offending agent. Cyclovir is rapidly excreted in the kidneys and the urine, but it has less solubility in the urine and precipitates in the renal tubules. This causes intratubular obstruction and direct renal tubular toxicity, and less commonly it causes acute kidney injury through an acute tubular necrosis or through an acute interstitial nephritis. More common with large IV doses and with oral doses. Next up is acute interstitial nephritis. So causes here would be like your drugs, penicillins, TMP, SMX, cephalosporins, and NSAIDs. Also rifampin, diuretics, and less commonly it could be caused by infectious agents like Legionella, Mycobacterium, TB, and Streptococcus. Clinically, interstitial nephritis shows up with a maculopapular rash, fever, and any kind of new drug exposures, as well as they can present with or without arthralgias. On laboratory findings, there can be acute kidney injury, there can be pyuria, hematuria, white blood cell casts. There can also be eosinophilia, as well as urinary eosinophils, and those eosinophils are less frequent and absent in NSAID-induced acute injury. Renal biopsy also shows inflammatory infiltrates as well as edema, and the management here of interstitial nephritis would be to discontinue the offending drug and to give systemic steroids, glucocorticoids. And the symptoms can appear 5 days to several weeks after you start them on any of those medications, penicillins, TMP, SMX, cephalosporins, or NSAIDs. Moving on, we have clinical features of analgesic nephropathy. So clinically, the presentation of analgesic nephropathy is that it is associated with long-term use of one or multiple analgesics like aspirin or ibuprofen, and that's for chronic headaches or other somatic complaints. It's usually asymptomatic, but it can have chronic tubular interstitial nephritis or hematuria, and that's due to the papillary necrosis that analgesic nephropathy can occur. So polyuria and sterile pyuria are early on findings, whereas chronic kidney disease also occurs. The diagnosis of analgesic nephropathy is with an elevated creatinine, with urine analysis is going to show hematuria or sterile pyuria, meaning that you'll have white blood cell casts in the urine. You can have mild proteinuria, less than 1.5 grams a day, and the CT scan is going to show small kidneys with bilateral renal papillary calcifications. Most common form of drug-induced chronic renal failure is analgesic nephropathy, so the patients typically are asymptomatic and they're found incidentally with high levels of creatinine. Analgesics are going to cause vasoconstriction of the medullary blood vessels, specifically the vasa recta, and that's going to cause papillary ischemia, which will then cause prominent and painless hematuria, because it's an analgesic. Painless hematuria. Significant papillary necrosis and sloughing off, and that's going to lead to renal colic. Hypertension, mild proteinuria, and impaired urinary concentration develops as the disease is going to progress. And then advanced diseases can present with nephrotic range proteinuria. And it's common in females between the ages of 50 to 55, and it's also seen after a cumulative ingestion of 2 to 3 kilograms of whatever type of drug, so about 4 pounds. Patients with chronic analgesic abuse are also more likely to develop premature aging, atherosclerotic vascular diseases, as well as urinary tract cancer. Moving on to acute tubular necrosis, the suggestive findings for acute tubular necrosis would be a Bunn creatinine ratio of less than 20 to 1. The urine osmolarity is around 300 or 350 milliosmoles, but it's never less than 300. So it's that 300 to 350 range. Urine sodium is more than 20 milliequivalents per liter, and the FeNA is going to be more than 2%. Also, the big one is the muddy brown casts. in the urine, and that consists of renal tubular epithelial cells. It's not as very specific, but it's very sensitive test. And I'm always thinking acute tubular necrosis if I see any kind of muddy brown cast, even on those tests where you see the crystals in the urine, it'll show these brownish pigments floating around. That's right there. It's telling you acute tubular necrosis. Next is rhabdomyolysis-induced acute renal failure, and the risk factors for rhabdomyolysis is going to be immobilization as well as cocaine abuse. Immobilization is a cause of direct muscle damage, and that causes an increase in CPK and potassium as well as myoglobin. Cocaine is going to cause systemic vasoconstrictions that leads to diffuse ischemia, seizures, agitation, and an incidental trauma, as well as hyperpyrexia and a direct toxic effect on myocytes. All these are going to cause an increase in muscle breakdown and an increase in CPK levels, potassium, and myoglobin, because it's all being spilled out, and it occurs in around 20% of cocaine overdoses. Renal failure in rhabdomyolysis is going to be caused by acute tubular necrosis, and the risk of myoglobin-induced acute renal failure is going to be increased if CPK is more than 20,000 units per liter. On dipstick, you're positive for blood, but not for red blood cells. And the risk decreases with aggressive hydration. Mannitol and urine alkalinization can be beneficial. Next up is prerenal azotemia. So prerenal azotemia starts off with hypotension and volume depletion, such as in sepsis, and that sepsis can cause prerenal azotemia. So you want to give IV isotonic saline to improve that condition. And the condition is going to temporarily worsen because of the acute tubular necrosis or the septic shock involved. So if there's hypotension, there's going to be a decrease in effective renal blood flow, and that decrease in renal blood flow is then going to activate the renin-angiotensin aldosterone system. The angiotensin is going to constrict the glomerular afferent, the efferent arterial, the efferent more than the afferent, and that's going to maintain intraglomerular pressure, and it's going to maintain the GFR despite that there's a decrease in renal blood flow. So the decrease in renal blood flow is also going to release prostaglandins, which are going to dilate the afferent arterial, and that's going to maintain the GFR. So it's going to continue if you continue the volume depletion, that's going to overwhelm the response, and the intraglomerular pressure is going to eventually fall. GFR is going to fall despite maximal effort of the efferent arterial constriction. So eventually it's just going to fail. In prerenal azotemia, there's going to be an increase in antidiuretic hormone, and the renal tubulars are going to avidly reabsorb sodium and water. Urea absorption is also going to increase, and the buncreatinine ratio is going to be more than 20. If left persistent with prerenal azotemia, untreated renal hypoperfusion is going to happen, and that's going to lead to an intrinsic renal failure due to an ischemia. That's going to lead to acute tubular necrosis with the ischemia, and a buncreatinine ratio will then become less than 20 due to the impaired in absorption. So what are some of the aggravating factors of prerenal azotemia? Would be like nephrotoxic drugs like NSAIDs, aspirin by inhibiting the prostaglandin effect. Metformin is nephrotoxic. ACE inhibitors and ARBs, they prevent the action of angiotensin on the arterioles, and thus will decrease fluid intake commonly in elderly patients, and that leads to a decrease in intravascular volume, and diuretics are going to further worsen volume depletion. And we've said metformin is nephrotoxic because it causes lactic acidosis and acute kidney injury, liver failure, and sepsis, and should also be held until renal function improves. Okay, let's talk about the Renin-Angiotensin System since we were on that topic. So let's say you have a decrease in renal blood flow. That decrease in renal blood flow is going to cause a decreased glomerular filtration rate. And then that's going to stimulate the juxtaglomerular apparatus, or the JG apparatus, to secrete renin because there's no flow to the kidney. The high levels of renin are then going to stimulate the angiotensinogen in the liver, and that angiotensinogen is then going to increase angiotensin 1. Angiotensin 1 is then going to stimulate angiotensin 2 through angiotensin converting enzyme, which is part of the lung. So the endothelium of the lung vessels are going to secrete ACE to convert angiotensin 1 to angiotensin 2. And then finally, angiotensin 2 is going to cause sodium retention, and that's the direct effect on the kidney is through sodium retention. Also aldosterone production and vasoconstriction. Now, let's say you have CT contrast-induced nephropathy. So the pathogenesis here is that you get renal vasoconstriction and tubular injury because of the contrast. So the risk factors here is a history of diabetes and chronic renal insufficiency with elevated baseline creatinines. Especially, those are the ones that are especially at risk. So they present with spikes in creatinine within 24 hours of the contrast being made, and then it's followed by a return to normal renal function within a week. So prevention here would be to adequately give them hydration before the CT with isotonic bicarbonate or normal saline is the single most important intervention for the prevention of it. You want to start prior to the procedure and should continue several hours after the procedure. So you want to always maintain the patient hydrated at this point. Acetylcysteine has also been shown to prevent nephropathy for contrast-induced nephropathy, and it's likely due to the vasodilatory and antioxidant properties that acetylcysteine has. Also, you want to advise to discontinue any type of NSAIDs or cyclooxygenases due to the vasoconstriction effect. And then prednisone is going to prevent contrast-induced hypersensitivity in patients with a known allergy. So if they are allergic to contrast and they have to still do the contrast, then prednisone is given to prevent that hypersensitivity reaction. And symptoms, again, are going to include flushing, angioedema, urticaria, bronchospasms, etc., all the hypersensitivity reactions. It does not prevent the nephropathy, but it can cause fluid retention in patients with renal insufficiency, and that could lead to hypertension. Then moving on, we have chronic renal failure. This is a gradual loss of nephrons. So this is something chronically, so gradual loss of nephrons. And then whatever nephrons remain are going to be the ones that are maintaining the kidney function. And that's going to be the one that's available to excrete daily acid loads and produce more ammonia buffers that removes hydrogen as ammonia in the urine. So ammonium gets produced to remove the hydrogens, and then ammonia is peed out. In metabolic acidosis is rarely seen until advanced renal dysfunction, and that would be a GFR of less than 20. A non-anion gap metabolic acidosis and hyperkalemia that occur out of proportion to the renal dysfunction indicates a renal tubular dysfunction. Now, uremic coagulopathies, that's commonly seen in chronic renal failure. Abnormal bleeding and bruising is characteristic, and nowadays ecchymosis and epistaxis is also seen. Major bleeding manifestations are seen due to the advent of dialysis. However, GI bleeding and hemopericardium, as well as subdural hematomas and bleedings from the surgical or invasive sites, can still occur due to a uremic coagulopathy. On pathophysiology, it could be multifactorial. The major defect here involves platelet vessel wall and platelet-to-platelet interaction. So several uremic toxins have been implicated in the pathogenesis of platelet dysfunction, and that's seen in chronic renal failure. The chief among which is guanidinosuccinic acid. On labs, there's a PT and PTT and thromboplastin time that it's normal. Bleeding time reflects the platelet function, and that's abnormal. And the platelet count is normal. So it's just the bleeding time. It's a function of the platelets, not the actual platelets themselves that are affected. So think of it like if the platelets are drunk because of the uremia. So they're not working. There's no reaction here of agents like desmopressin, which is DDAVP, cryoprecipitate, and conjugated estrogens have been used to correct the coagulopathy in uremic patients. The DDAVP, the desmopressin, is going to increase the release of factor VIII, which is von Willebrand's factor multiples from endothelial storage sites. Here's a quick test question. Which of the following coagulation factors will not be decreased in somebody with any kind of liver disease or abnormal liver function? And that would be factor VIII, and that's because von Willebrand's factor VIII is actually made and stored in the endothelial cells, not in the liver. So there you go. So platelet transfusion isn't indicated because transfusing the platelet quickly becomes inactive. It's kind of like it's not a platelet problem. You have the platelets, but they're just swimming around in acid or in uremia. So the minute you put in more platelets, all you're doing is causing that blood to be just saturated with platelets that aren't working. Okay, next is end-stage renal disease. In end-stage renal disease, the only two treatment options are transplant or dialysis. So transplant is from living-related donors. That's preferred over anything. So the advantages of transplants is that it's a better survival and the quality of life for the patient. I mean, you get a new organ, it's kind of like getting a new part for your car. It's better to get a brand new part than it is to repair the old part in some cases. So here, since we can't really repair it, the next best step is to transplant. And the best is a living donor transplant, a living relative donor transplant. That has the better survival and quality of life. It's a better control on the anemia, the bone disease, and the hypertension. And there's normal return of the endocrine, reproductive, and sexual functions, and enhanced energy. Thus, full-time employment and more strenuous activity is possible. Improvement or stabilization of autonomic neuropathy in diabetics persists or becomes worse in dialysis patients. So then the 1-year survival is 95% and the 5-year survival is 88%. Now the dialysis is going to have a 5-year survival, and in non-diabetic patients it's about 30 to 40% versus in diabetics it's only about 20% survival rate. So what are the indications of dialysis? We explained this last time, but dialysis is the mnemonic AEIOU, and that stands for A for acidosis. So a metabolic acidosis with a pH of less than 7.1, that's refractory to medical therapy. The E is for electrolyte imbalances. The I is for ingestion of toxins and drugs. O is for overload or volume overload, and U is for uremia. So the electrolyte abnormalities is like a symptomatic hyperkalemia, EKG changes or ventricular arrhythmias, as well as severe hyperkalemia, which is a potassium level that's more than 6.5 milliequivalents, and that's refractory to medical therapy. Ingestions, you have toxic alcohols like methanol and ethylene glycol, as well as salicylates, lithium and sodium valproate, as well as carbamazepine. So all those can become toxic, and you're going to need dialysis. Volume overload is refractory to diuretics. So if the diuretics aren't working to bring your volume down, then dialysis is your next step. And symptomatic uremia. So if you're uremic and you have encephalopathy, which is like asterixis due to the interruption of neural pathways that sustain muscle contractions, that can occur in uremic encephalopathy, as well as hepatic encephalopathy and chronic CO2 retention. And the treatment here would be dialysis, like we said, in uremic encephalopathy, as well as lactulose and hepatic encephalopathy. And you want to decrease albumin and increase bilirubin, and that when that's present. So uremia would be symptomatic encephalopathy, pericarditis, or bleeding. Most common cause of death in dialysis and renal transplantation is going to be cardiovascular disease, and that accounts for 50% of deaths in dialysis patients. 20% are going to be due to an acute MI, and 60% are due to sudden cardiac death. Risk factors for cardiovascular disease not related to dialysis patients on dialysis have already multiple risk factors for cardiovascular diseases. So those risk factors would be like hypertension, that's the most common cause at 96%. Then you have diabetes as a cardiovascular risk factor, low serum HDL levels, left ventricular hypertrophy, coronary artery disease, especially in those who have end-stage renal disease with at least 50% narrowing of at least one coronary artery. And then increase in age. So the average age at the start of dialysis is going to be 60 years old. So the risk factors for cardiovascular disease due to end-stage renal disease and dialysis is end-stage renal disease by itself is an independent risk factor for cardiovascular disease. Anemia, metabolic abnormalities, and remember hyperphosphatemia, because the kidneys aren't working, you can't expel that phosphate level, so it just becomes increased and toxic. As well as parathyroid hormone, because parathyroid hormone is also known as phosphate trashing hormone, right? Whenever PTH is high, phosphate is low, but in this case, phosphate is so high, PTH is also increased to try to eliminate it. But there's renal failure, so it's not going to work. There's also an increase in homocysteine levels due to impaired metabolism and a decrease in excretion, and increased atherogenesis due to oxidant stress due to uremia or bioincompatible renal replacement therapies. Also, there's increased calcium intake, so calcium is given to correct the hyperphosphatemia in dialysis patients. This is going to enhance coronary artery calcification. The inhibition of nitric oxide, this is the most common finding in dialysis patients, and that can cause vasoconstriction and hypertension. Remember, nitric oxide is a dilator, right? So here, if you inhibit nitric oxide, then you will cause vasoconstriction and hypertension, so that's not good. Infections in 15 to 20% of dialysis patients, as well as withdrawal of dialysis in 20% of patients, causes death. Next up is renal transplant dysfunction. So in early onset or early post-op period, that manifests as oliguria, hypertension, and there's going to also be an increase in creatinine, the bun-creatinine ratio. And that can be explained by a number of causes like urethral obstructions, there's acute rejection, cyclosporin toxicities, vascular obstructions, acute tubular necrosis, and so on. So the diagnosis of renal transplant dysfunction would be by scanning the kidneys with a radioisotope. And you can also do a renal ultrasound, an MRI. You can do a renal biopsy that can be employed in conducting a differential diagnosis, and as well as serum cyclosporin levels for cyclosporin toxicity if the patient's on cyclosporin. The treatment, if acute rejection is suspected, is to rapidly institute an anti-rejection therapy that includes high doses of steroids. So whenever you want to fix something, you don't know the answer, steroids is always a good go-to drug. Next up is renal cysts. Characteristics of renal cysts are going to be either simple cysts or malignant cysts. So a simple cyst is going to be a thin cyst that's smooth, has a regular looking wall. It's unilocular. There's no septi or septates. There's none of them. It's homogeneous in content. There's absence of contrast enhancement on CT or MRI, so it's not going to show up. And it's usually asymptomatic in individuals, so no follow-up is really needed with simple renal cysts. Versus malignant cystic masses, these are thick, irregular-walled cysts that are multilocular. They have multiple septae, and those septates are either thick or calcified. It could be heterogeneous content, so they can have a solid or a cystic renal cyst. And the presence of a contrast enhancement on CT or MRI, these are going to light up on CT and MRI. And these can cause pain, they can cause hematuria or hypertension, so they are symptomatic. And so finally, that will require follow-up imaging as well as urological evaluations for malignancy. So remember, a simple cyst has thin walls, no solid components, no enhancements. On CT, it's going to show up just like a dark round circle in the kidney, and that's fine. It's just there's no follow-up needed. It's okay. Versus a malignant mass, so it's going to be the same kind of CT around the same area. You'll see a round mass, but the round mass isn't going to be a complete circle. It's going to have these projections, going to be kind of lumpy, and it's going to be kind of weird looking inside, spiculated, there's calcifications, there's heterogeneous components, the walls are irregular. So, I mean, when you see it, you can tell the difference. A simple cyst just looks like a mass that's just a solid circle, and a malignant mass looks like there's your typical picture of, hey, there's something wrong here. This looks weird. All right, so autosomal dominant polycystic kidney disease. This is going to be hypertension with a palpable bilateral flanked mass and microhematuria. There's extrarenal complications as well. There's could be intracranial baryaneurysms, which are common and dangerous when coupled with hypertension. But routine screening here won't be necessary, and it's seen only in 5 to 10% of patients. Hepatic cysts are very common. They're the most common extrarenal manifestation for autosomal dominant polycystic kidney disease. Valvular heart diseases like mitral valve prolapse and aortic regurgitation, as well as colonic diverticula and abdominal wall and inguinal hernias. The prostate, we're going to compare either benign prostatic hyperplasia and prostate cancer. So here, so in BPH, or benign prostatic hyperplasia, this happens in more than 50 years of age. It affects the central portion or the transitional zone of the prostate. And on exam, you'll see a symmetrically enlarged and smooth prostate that can have elevated PSA. Versus prostate cancer, this happens in younger populations greater than 40 years of age, usually African Americans with a family history, and it's usually the lateral lobes of the prostate, but it can be anywhere. On exam, it could be an asymmetrically enlarged prostate versus the benign one, which remember that was symmetrical. Here it's asymmetrical with nodules, and the prostate feels firm. And there's a markedly elevated PSA with prostate cancer. So in BPH, the evaluation of BPH would be current recommendations suggesting urine analysis in patients with BPH based on the history and rectal examination, as well as to evaluate for hematuria. So look for bladder and kidney stones, as well as infections. A PSA is going to be recommended for prostate cancer in men with life expectancies that are greater than 10 years. And serum creatinine tests are going to check out bladder outlet obstruction. So that should be considered in any patient with BPH and acute kidney injury. So you're going to think of doing a serum creatinine test because they could have a post-renal obstruction, causing an increase in creatinine as well as kidney damage. Remember, the kidneys can back up and become hydronephrosed, and usually the creatinine is usually not elevated in those with unilateral obstruction because the other kidney can work. So unless it's both kidneys that are obstructed, then that would have more effect. Okay, treatment is for BPH would be urinary catheterization for quick relief of the obstruction, and medical treatment would be alpha blockers like tamsulosin, doxazosin alone or in combination with 5-alpha reductase inhibitors like finasteride for symptomatic relief. Remember, the alpha blockers, they work on the smooth muscle and they vasodilate. So as you vasodilate, that helps in clearing out an obstruction. It's good for stones too, urethral stones. For surgery, surgery is reserved for severe symptoms like bladder outlet obstruction or recurrent UTIs, as well as if you fail any kind of medical therapy. Renal cell carcinoma. Patients with renal cell carcinoma are going to experience flank pain, hematuria, and a palpable abdominal renal mass. There can be scrotal varicoceles on the left, usually because of that 90-degree angle of the left renal vein, as well as paraneoplastic symptoms like anemia and erythrocytosis, thrombocytosis, fever, hypercalcemia, and cachexia as well. The abdominal renal mass is going to give you that classic triad seen in 10% of patients, and when they present, they're going to suggest with metastatic or advanced disease. So when they present to you, they'll be already in metastatic presentation. So the disease is already advanced. Hematuria, 40% is going to suggest invasion of the collecting system. So the most common renal cell carcinoma patient, most renal cell carcinoma patients are asymptomatic until the disease is advanced. 20% may have constitutional symptoms like fevers, night sweats, weight loss, anorexia, or easy fatigability. On CT scan of the abdomen, that's the most sensitive and specific test, and that should be obtained when the index of suspicion is high. Bladder cancer, the workup for bladder cancer, is initial evaluations of gross hematuria on urinalysis is used to rule out infections and to confirm microhematuria. So more than 3 red blood cells per high power field, because red urine can occur in other conditions like microglobinuria. You eat a lot of beets that are red. Rifampin, remember, makes that red urine. So you need to do the microhematuria to rule out urinalysis to rule out infection. Cystoscopy is going to be recommended as well for all patients with unexplained gross hematuria or with microscopic hematuria and other risk factors of bladder cancer. Also remember if you have blood at the end of micturition, at the end of urinating, then that's also an indication for bladder cancer. Versus blood hematuria at the beginning of micturition, that would be signs of like a stone, a kidney stone. Indications for cystoscopy: on gross hematuria with no evidence of glomerular disease or infection. So that's an indication for cystoscopy. Just if you have hematuria with no other evidence of glomerular diseases or infection. Also, if you have microscopic hematuria with no evidence of glomerular diseases or infection, but increased risk of malignancy. If you have recurrent urinary tract infections, or if there's obstructive symptoms with suspicions of strictures or stones, that is an indication for cystoscopy. There's irritative symptoms without urinary infections, and abnormal bladder imaging on urine cytology. These are all indications for cystoscopy. A CT scan with contrast should also be performed to evaluate bladder and urethral, the bladder and the urethra. And the average age for the diagnosis is 65 years of age. Screening is not recommended because of the low incidence and poor predictive values of current screening tests, however. So what are some causes of gross or microscopic hematuria? Renal causes would be like renal cell cancer, IgA nephropathy. Urethral causes would be like stones or strictures. In the bladder, microscopic hematuria can be an indication of cancer or cystitis. And in the prostate and in the urethral glands, microscopic hematuria can be a sign of BPH, prostate cancer, or urethritis. So those abnormalities, though BPH can cause hematuria, you still want to rule out bladder cancer, and you want to do that with a cystoscopy. And if that comes back negative, then you want to start off with the BPH medications. So the risk factors for bladder cancer, number 1 is always going to be cigarette smoking. Cigarette smoking is the most important risk factor for bladder cancer, while smoking cessation is going to decrease that risk. Patients still have a high risk than non-smokers, even up to 20 years after smoking cessation, because the carcinogens just already deposited and sedimented on the smooth muscle of that bladder, unfortunately. Even if you're not a smoker and you're just exposed to high levels of smoking, that could be a risk factor for bladder cancer. Also, ages greater than 35, certain occupational exposures like painters and metal workers, because those can all cause toxic, noxious chemicals that can be chronically irritative to the bladder and cause bladder cancer. There's chronic cystitis, iatrogenic causes like cyclophosphamide, and finally pelvic radiation exposure. But cigarette smoking is going to be the most important risk factor for bladder cancer, because there's a lot more people in this world that smoke than all the other ones. There's more people that smoke than work with metals or that are painters. So while smoking cessation does decrease the risk, patients still have a high risk. They're more at risk than non-smokers, even up to 20 years after smoking cessation, like we said. Cyanide toxicity is the next topic. So my manifestations of cyanide toxicity or cyanide accumulation would be on the skin. You'll see flushing. There's going to be a cherry red color of the skin. Cyanosis can also occur later on. CNS symptoms, they can have headaches, altered mental statuses, as well as seizures and coma. Cardiovascular causes would be arrhythmias. In the respiratory tract, tachypnea is going to be followed by respiratory depression, as well as pulmonary edema with cyanide toxicity. In the GI, they'll present with abdominal pain, nausea, and vomiting. And in the renal, manifestations would be like metabolic acidosis from lactic acidosis and renal failure. So some causes of cyanide toxicity are the combustion of carbon and nitrogen containing compounds like wool and silk. So think of a burning building, and it's not so much the smoke, but it's the actual upholstery, that carpets, the draperies that are burning, and that can let out a mix of carbon and nitrogen, causing cyanide toxicity. So industrial exposures like metal extractions and minings, as well as medications like sodium nitroprusside. They always love to ask the question, somebody who's on nitroglycerin or they're given nitroglycerin, what do you have to worry about is cyanide toxicity. So pathophysiology, cyanide is going to bind to the cytochrome oxidase and inhibit the mitochondrial oxidative phosphorylation, causing anaerobic metabolism that starts off decreasing ATPs, and finally, because you have a decrease in ATPs, you'll have a lactic acidosis. Then we have sodium nitroprusside, is a potent arterial and venous vasodilator. It's often used for hypertensive emergencies. It contains 5 cyanide groups, and this rapidly converts cyanide and eventually becomes thiocyanate, and that's eliminated by the kidneys eventually. But prolonged infusion, more than 24 hours at a high rate, can lead to a cyanide toxicity, especially in patients with chronic kidney disease, because they just can't eliminate it from the body, so it builds up. So prevention would be low infusion rates of less than 2 micrograms, but remember, you don't have to know about dosages. Short-term use and close monitoring. And you want to treat cyanide or sodium nitroprusside toxicity with sodium thiosulfate. Moving on to pharmacology, thiazide diuretics are going to be your chlorthalidones and hydrochlorothiazide. Side effects of these medications is that they can impair insulin release from the pancreas, as well as glucose utilization in peripheral tissues. And that's going to basically lead to a glucose intolerance, and it's seen more commonly in diabetes, mellitus, and in metabolic syndrome. So patients with hypertension, dyslipidemia, and abdominal obesity. There's also metabolic adverse effects that are dose dependent. That most commonly occurs with chlorthalidone than any other thiazide diuretic. So remember, chlorthalidone has the most metabolic adverse effects. However, chlorthalidone is still preferred in this class compared to other thiazides based on the all-HAT trial, where that all-HAT trial is chlorthalidone was associated with a decrease in cardiovascular mortality, and that was compared to others, antihypertensives like ACE inhibitors, dihydropyridine, calcium channel blockers. So it's still preferred. So chlorthalidone does have a better effect in that case. However, remember that chlorthalidone does have an increased risk of metabolic adverse effects. So diuretics are often used in cor pulmonale, but should be used cautiously, and can cause acute kidney failure because it lowers the volume. Because you lower that volume, you're going to decrease cardiac output. The decrease in cardiac output is going to have a decrease perfusion to the kidneys. That's going to cause prerenal azotemia as well as acute kidney injury. Next is succinylcholine, and this is a depolarizing neuromuscular blocker, and it's used for rapid sequence intubation as it has a rapid onset. So it starts off 45 to 60 seconds, and it lasts about 6 to 10 minutes. That's its action. So side effects can cause significant potassium release and life-threatening arrhythmias. So some of the contraindications to succinylcholine would be patients with risks of hyperkalemia, and that includes patients that are crush injury victims or burn injury victims, more than 8 hours old. So they have a high risk of rhabdomyolysis, as well as patients with demyelinating syndromes like Guillain-Barré and patients with tumor lysis syndrome. Non-depolarizing agents such as vercuronium and rocuronium, those are better in such patients. So if you have any kind of patients with those types of things, Guillain-Barré, crush injuries, burn injuries, and you're asked which one would be better for rapid sequence intubation, you would prefer a non-depolarizing like vercuronium or rocuronium over succinylcholine. So there is hepatic dysfunction associated with succinylcholine, but it's not a contraindication for succinylcholine because it does lower at lower doses. It could be used, and there's no effects of calcium on calcium concentration. Diuretic abuse. Some people abuse diuretics for weight loss. So think of that in the question stem. See a person who's trying to lose weight or has been aggressively trying to lose weight or something along those lines, and they've been taking and suddenly they have hypovolemia, or you see their labs and their sodium levels are low. Think of a diuretic abuse with hyponatremia as well as hypokalemia and hypochloremia, especially the hypochloremia part of it, and elevated urinary sodium and potassium because it's all getting peed out into the urine, so the urine concentration of these electrolytes will be high. Then you'll have cerebral salt wasting that also can lead to hypovolemia with hyponatremia, as well as an increase in urinary sodium, more than 20 milliequivalents. But it's always secondary to brain surgery or brain injury. So the diagnosis of orthostatic postural hypotension is within 2 to 5 minutes of standing from a supine position. So they can have a drop in the systolic blood pressure of more than 20 millimeters of mercury, or a drop in the diastolic blood pressure of more than 10. So how do you see that is that a patient comes in and they have a blood pressure of, let's say, 140 over 90, and when they stand up, it goes to 120 over 70, okay, or 120 over 80. That would be considered postural hypotension, and short-acting insulin is typically recommended for target blood glucose control if that's the cause of it. Pointers here for renal pharmacology is that aminoglycosides can be used in patients with renal dysfunction, but their serum levels and the patient's renal function has to be monitored closely because of their side effect profile. They are being used with decreased frequency in older patients. And then finally, phenylpyridine, that's an analgesic for urinary tract mucosa that's frequently used to treat the dysuria of cystitis. Examples would be like after an infection or after instrumentation. It can worsen a stone formation. It's not known why, but phenazopyridine is associated with stone formation. And that is the end of internal medicine for renal. So the next topic is going to be renal pediatrics. And here we're going to start off with hypovolemic hyponatremia. So this is when you're giving IV food boluses. Only isotonic fluids like normal saline or Ringer's lactate should be used when you have a hypovolemic hyponatremia. So next, let's talk about pyloric stenosis. In pyloric stenosis, we're going to start off with vomiting. So a patient's vomiting, and they're going to have loss of gastric acid, and they're going to have also loss of sodium chloride in water. With the loss of gastric acid, it's going to be the initiation of a metabolic alkalosis and a hypochloremia. So you're losing all those chloride ions when you're vomiting, and you get a metabolic acidosis because you're losing acid. With the loss of sodium chloride and water, you also get hypovolemia. Hypovolemia, again, is going to decrease renal perfusion pressure, and then that's going to stimulate the angiotensin 2 to be increased. And like we know, angiotensin 2, when increased, stimulates aldosterone to do two things. Aldosterone is going to secrete potassium ions, causing you to have a hypokalemia. And aldosterone is going to have an increase in hydrogen secretion. And that's how you're going to maintain metabolic alkalosis, by increasing aldosterone. Angiotensin 2, when it's high, it's also going to cause an increase in bicarbonate reabsorption. And that bicarbonate reabsorption is going to also maintain a metabolic alkalotic state. Urinary tract infections, microbiology, E. coli is the most common cause of UTIs. Clinical features of UTIs are going to be cystitis and pyelonephritis. Cystitis is going to give you dysuria, frequency, urgency, hematuria, suprapubic pain, whereas pyelonephritis is going to give you fever more than 100.4 degrees, and it's also going to give you chills and flank pain, CVA, angle tenderness, costovertebral angle tenderness, as well as nausea and vomiting with or without the cystitis symptoms. The diagnosis of UTIs is through urine analysis and urine culture, and treatment is with antibiotics. So children less than 2 years of age are at increased risk of complications, and they should be treated for 1 to 2 weeks of antibiotics. So UTIs have to be diagnosed and treated promptly, because it does involve the kidneys, and the risk factors in girls of all ages because of their short urethras. Also sexual intercourse, because that introduces bacteria into the introitus, and the bacteria then ascends up the urethra into the bladder. Also uncircumscribed boys, circumcision, if they haven't been circumcised, ages less than a year, and underlying renal abnormalities like vesicoureteral reflux or a posterior urethral valve are risk factors for UTIs. Symptoms during infancy would be nonspecific and vague symptoms like fever, fussiness, a decreased urine output, that's how they would present, as well as with abdominal or flank pain and dysuria. And that would be difficult to determine because infants are nonverbal, so you have to actually kind of see the symptoms and how their expressions are. The presence of fever more than 102 in any child that's less than 3 years old should give you a prompt evaluation for occult UTI. So how do you diagnose? These are the diagnostic tests to do for UTIs. So serum and bun creatinine ratios, those are going to estimate the renal function. Urine dipstick is going to give you a qualitative measurement of urine properties. Urinalysis is going to give you a quantitative measurement of urine properties as well. And urine culture is going to identify as well as quantify and give you a susceptibility and testing of bacterial colonies. So how would you do this is with a midstream clean catch urine specimen for children who don't wear diapers. External genitalia needs to be cleaned thoroughly to prevent contaminations with the skin flora. And infants and toddlers in diapers should then undergo straight catheterization of the urethra. That way you can obtain a sterile urine sample. A clean catch specimen are unreliable in infants who wear diapers because of the high likelihood of the skin flora that's contaminating the area. Indications for renal and bladder ultrasound in infants and children less than 2 years of age or 24 months with a first febrile UTI. That's an indication to give a renal bladder ultrasound. Also recurrent febrile UTIs in children of any age. UTIs in a child of any age with a family history of renal urological diseases, as well as hypertension or poor growth. And children who don't respond to antibiotic treatment should all undergo renal and bladder ultrasound. Ideally, the ultrasound should be performed after improvement of the fever and symptoms because you want to avoid false positive results from an acute inflammation. If persistent of worsening symptoms, then you want to perform an ultrasound immediately to assess for renal abscesses. And you also want to repeat the blood work and urine culture only in those patients who fail to improve after about 2 to 3 days of antibiotics. and there's no need to prove or cure if clinical improvement's seen. Okay, so recurrent UTIs in infants and children. This is a serious problem that often involves kidney and indicates congenital urinary tract abnormalities. Most common abnormality in UTIs in infants and children are going to be vesiculoureteral reflux. So vesiculoureteral reflux is divided into different grades. So you have grades 1 through 5. Grade 1 would be that it's into a non-dilated ureter. Grade 2 is into the pelvis and the calyces without dilation. Grade 3 would be a mild to moderate dilation of the ureter, as well as renal pelvis and calyces with minimal blunting of the fornices. Grade 4 would be moderate urethral tortuosity and dilation of the pelvis and the calyces. And grade 5 would be a gross dilation of the ureter, the pelvis, the calyces, as well as loss of papillary impressions and a urethral tortuosity. So this can cause a hydroureter as well as a hydronephrosis. And the diagnosis first, it's the first UTI at 2 to 24 months. That's going to, again, require a pelvic or renal ultrasound to look for any kind of anatomical abnormality that predisposes to a vesiculoureteral reflux. If that comes back normal, then reassuring and no need to perform a VCUG after the first one. In children that are less than 2 years with recurrent UTIs or newborns less than a month old, or if it's their first UTI from an organism other than E. coli, or a renal ultrasound that does show any type of renal scarring or hydronephrosis, then the definitive diagnosis is going to be made with a voiding cystourethrogram. On renal ultrasound, you want to do that to screen for hydronephrosis, and then recurrent or chronic pyelonephritis can lead to blunting of the calyces, and that would be like a calyceal clubbing, as well as focal parenchymal scarring. Renal scintigraphy with dimercaptosuccinic acid is the preferred modality for long-term evaluation for renal scarring. The renal function is also followed by serial creatinine measurements. And you want to monitor these patients closely for complications of chronic renal insufficiency, like hypertension and anemia. A posterior urethral valve is the next topic, and that's the most common cause of UTI obstructions in newborn boys. So a posterior urethral valve is an abnormal fold in the distal prosthetic urethra that obstruct the urinary flows. That's going to lead to a progressive dilation of the bladder, a dilation of the ureter, and as well as a dilation of the kidneys. They also can present with oligohydramnios in the second trimester, and that increases perinatal mortality. Potter's sequence is a urinary tract abnormality that causes anuria or oliguria in utero. Tongue twisters here. So anuria, oliguria in utero, and then that is going to cause oligohydramnios. Oligohydramnios, again, is going to give you your flat faces because there's no fluid in the amniotic sac. So the kid is just with his face flat up against the wall. Limb deformities as well, and you have your pulmonary hypoplasia. The other affected infants can present with poor urinary streams, straining with voiding. There's urosepsis and failure to thrive, as well as renal failure. And the diagnosis is confirmed by voiding cystourethrogram as well as a cystoscopy. Treatment options are going to include a pelvic urethral vesicular ablation and urinary diversion. And the prognosis is, despite prenatal diagnosis and early surgical intervention, patients are at high risk for permanent kidney damage, unfortunately. Next up is enuresis, and this is a urinary incontinence in children that are more than 5 years of age. There's primary enuresis and secondary enuresis. So primary is a child who's never achieved dryness. They're always They're always wetting their bed. Sorry, guys. Secondary enuresis would be a return of the incontinence after more than 6 months of dryness. Primary enuresis is also known as monosymptomatic or isolated enuresis, and by definition, this is a urinary incontinence in children that are greater than 5 years old. The workup here would be to do a urinalysis as well as urological imaging for children with significant daytime symptoms and a history of recurrent UTIs. Management of the primary enuresis would be behavioral modifications. Number one, you want to avoid surgery, avoid sugary caffeinated beverages. You want to avoid, you do want to avoid surgery. So avoid sugary caffeinated beverages. You want to avoid regularly during the day and immediately before bedtime. And drink ample fluids in the morning and then in the early afternoon, but then minimize that fluid intake right before you go to bed. Kind of common sense stuff. Reward system, you get a gold star chart, as well as an enuresis alarm. This is first line intervention when behavior modifications are failing. So, and the enuresis alarm is the best long-term outcome. It could take 3 to 4 months, though, to be effective. So, you got to be patient here. Pharmacotherapy is best for short-term improvement. There's a high risk of relapse. But if you have to go pharmacotherapy route, first line is going to be desmopressin. Oral desmopressin is used. The side effects here would be a risk of relapse, and that's 70% of patients. And hyponatremia. If too much fluid is consumed in the evening, intranasal desmopressin not used, the concentration of it increases the risk of hyponatremic seizures. So second line treatments would be TCAs. Monosymptomatic enuresis that is not explained by any other medical condition and that occurs at least twice a week after 5 years of age. That's what monosymptomatic enuresis is. And then oxybutynin is an anticholinergic medication that causes urinary retention, but that's reserved for use in combination with desmopressin to increase bladder capacity in children with daytime incontinence. Then we have your secondary enuresis. So there's causes of secondary enuresis like psychological stress, urinary tract infections, diabetes mellitus, as well as diabetes insipidus, and obstructive sleep apnea. So for psychological stresses, the associated symptoms here would be like behavior regression and mood lability. For UTIs, they'll have dysuria, hesitancy, urgency, and abdominal pain. For diabetes mellitus, patients will have polyuria, polydipsia, polyphagia, weight loss, lethargy, and candida infections. So not much changes here. So those are pretty much the common side effects of these illnesses to begin with. Diabetes insipidus, polyuria, polydipsia, and obstructive sleep apnea. You'll get your snoring, dry mouth, fatigue, hyperactivity, and irritability. And that's due to impaired sleep arousal. So diabetes mellitus type 1 has a bimodal distribution, so 4 to 6 years and early puberty. The next step in the evaluation of a diabetes mellitus is to include the urine analysis. You got to get a serum chemistry, hemoglobin A1C levels, and arterial blood gas analyses. And when their euglycemic is achieved with insulin therapy, they also can get glucosuria and polyuria. That should resolve. The glucosuria and the polyuria should resolve with insulin therapy, and that would cure the enuresis. Next up would be proteinuria in children. Proteinuria in children would be measured with a urine dipstick, and that could be positive in about 10% of school-age children. Proteinuria in children can be of 3 types. There's either transient proteinuria, which is intermittent proteinuria, orthostatic proteinuria, or persistent proteinuria. For transient proteinuria, this is the most common. It causes fever, stress, exercises, seizures, and volume depletion. Orthostatic proteinuria is very common in adolescent boys, and there's an increase in protein when the patient is upright and returns to normal when the patient is recumbent. If the urinalysis doesn't show any type of hematuria and is otherwise normal, then a urine dipstick should be repeated on at least 2 additional specimens. And if these subsequent tests are, again, negative for protein, the diagnosis is going to be transient proteinuria. So transient and orthostatic proteinurias are usually going to be benign conditions that require no further evaluation. The proteinuria persists on repeat sample, or if any additional studies are abnormal, you want to refer to pediatric nephrology and evaluate for underlying renal disease. And then further investigations are going to include 24-hour urine collections, renal ultrasounds, and renal biopsies. Next up is HSP, or Henoch-Schönlein purpura. This is an IgA-mediated leukocytoclastic vasculitis, which manifests with palpable purpura that symmetrically involves both lower legs and buttocks, and as well as the arms. They can have arthritis and arthralgias, and that's most commonly affected in the knees and in the ankles. That's a transient with no permanent damage to the joint. Abdominal pain, intussusception, renal disease, similar to IgA nephropathy, because it is IgA-mediated HSP. So lab findings here would be normal platelet counts, coagulation studies. Those are normal to increase in creatinines, and they could have hematuria with or without red blood cell casts and with or without proteinuria. And then treatment here would be supportive. You want to give them hydration with NSAIDs for most patients, and you want to hospitalize them and give them systemic steroids in patients with very severe symptoms. So renal involvement is 20 to 50% of cases with HSP. Mild disease is more common, and they present with microscopic or macroscopic hematuria, red blood cell cast, proteinuria, but it's usually non-nephrotic range, the proteinuria. Normally, it's going to be slightly increased, if anything, on the creatinine. And the severe disease is going to present with nephrotic syndrome, hypertension, and acute renal failure. Diagnosis is a clinical diagnosis in patients with those typical presenting signs and symptoms. So the diagnosis requires lower extremity purpura or petechia with at least one of the following. They have to have arthralgias or arthritis with the purpura, or renal involvement, abdominal pain that's colicky and throughout, and it's due to bowel wall vasculitises, as well as positive serology. So if you got any one of those with petechia and purpura, then that's HUS. And the atypical symptoms would be then needed to have a biopsy done, a renal biopsy, to help confirm the diagnosis. And then when you do that biopsy, you'll see the deposition of IgA and the mesangium. And that's the end of pediatric nephrology. And moving on, we have renal surgery, so the surgical part. So let's see the causes of hematuria. So hematuria throughout the urinary system, you'll have, these are causes of hematuria. So renal masses, benign or malignant masses, as well as glomerulonephritis, urolithiasis, polycystic kidney disease, pyelonephritis, urethral cancer, as well as trauma. These are all causing hematuria. And this is in the upper collecting system. But in the lower collecting system, you have something called terminal hematuria, which is indicative of maybe urethral cancer or cystitis. So it's either infectious cystitis or post-radiation cystitis. Also, urolithiasis can cause a terminal hematuria, benign prostatic hypertrophy, and prostatic cancer. And these are, you just see hematuria at the end of mixturation. And this is actually seen in the lower collecting system. And then finally, initial hematuria, where you get hematuria at the beginning of your stream. That's indicative of either trauma like catheterization or urethritis. So for trauma, all trauma patients should be evaluated with a cardiorespiratory stability, then spine immobilization until the spinal injury has been ruled out. You want to perform neurological examinations in patients as part of any kind of primary surgery or survey, And if there's any type of weakness and a decrease in pain sensation suggesting any type of spinal cord injury and the absence of obvious pelvic injury or blood at the urethral meatus, then you want to place a urinary catheter to assess for urinary retention and to prevent any kind of possible bladder injury from an acute distension. Then you also want to image to diagnose and evaluate the spinal cord damage, as well as surgical intervention for acute cord compression or neurological deficits or unstable vertebral fractures or dislocations of the vertebrae. You also want to protect the airway and mechanically ventilate patients, but obviously it's not needed if the patient is fully awake and has normal respiratory examination. That's obvious. For peripheral IV access, you want to also give additional IV access like a femoral line, but it's not needed if they're hemodynamically stable patients. These are obvious if adequate peripheral IV access is established. Okay, urethral injury, that is classified based on the anatomical location. So anterior urethral injuries are found in the anterior urethra, and that's a portion distal to the urogenital diaphragm. The causes of urethral injury is blunt trauma to the perineum, like a straddle injury, or instrumentations of the urethra. And the clinical findings would be like perineal tenderness or hematoma, normal prostates, bleeding from the urethra, and may not complain of inability to urinate. There's a delayed presentation, may be complicated by sepsis secondary to an extravasation of urine into the scrotum and the perineum or the abdominal wall. Now, posterior urethral injuries, those consist of prostatic or membranous urethras, and causes would be commonly associated with fractures of the pelvis. So if you see any kind of pelvic fracture, think of a posterior urethral injury. Clinical findings would be suprapubic pain, the inability to void following major trauma, despite the urge and wanting to void, they're going to have inability to void. Examination, there'll be blood at the urethral meatus. There's a high riding prostate due to displacement of the prostate by a pelvic hematoma and a scrotal hematoma, as well as a distended bladder and signs and symptoms of pelvic fractures. So here, a urethral injury is suspected clinically. What do you do next? A retrograde urethrogram. And you'd want to do that before you do a Foley catheter. That's going to determine whether the damage has occurred to the urethra and where it actually occurred. So blindly inserting a Foley is going to be contraindicated in suspected cases because it can actually cause infections and periurethral hematomas, and that all can cause an increased severity of urethral tears. Then an immediate surgical repair is occasionally done in cases of anterior urethral injuries, and most cases of urethral injuries are then going to be treated with urinary diversion via a suprapubic catheter while the primary injury and the associated hematomas are allowed to heal. After healing is complete, residual damage such as urethral strictures is used to assess, and it's used to be repaired. Bladder injury is going to require a retrograde cystogram with post-void films. That's used for the diagnosis of any type of bladder injury. Bladder injury may occur following a major trauma, especially pelvic fractures, and patients typically complain of gross hematuria. And here, finally, pointers is that IV cefazolin is an antimicrobial prophylaxis that's given before surgery to prevent wound infections, and that's usually given within an hour of the procedure. And that's the end of surgery for renal. And finally, we're going to conclude renal with OB-GYN. So renal stones, you're going to need special consideration, and the usual diagnostic studies can expose fetuses to radiation. Renal and pelvic ultrasound is the diagnostic study of choice, and it also detects signs of obstructions like hydroureter and hydronephrosis. Physiological hydronephrosis in pregnancy should be distinguished from pathological hydronephrosis, and that's due to the obstruction. A CT and IV pyelograms are contraindicated in pregnancy. There's a limited CT and low-dose CT urographies can be considered in the second or third trimester only if safer procedures are not helpful. And then obviously shockwave lithotripsy is contraindicated in pregnancy. You don't want to shockwave the baby. If a pregnant patient fails to improve with conservative measures, then a urethroscopy or a nephrostomy may be considered. So UTIs in pregnancy. So you can have asymptomatic bacteriuria, you can have acute cystitis or acute pyelonephritis. So in asymptomatic bacteriuria, clinical features would be a positive urine culture of more than 100,000 colonies. Especially in asymptomatic patients, they'll still have a positive urine culture. Screening is usually done at 12 to 16 weeks gestation, and the treatment reduces the progression to UTIs and the complications like preterm birth or low birth weight. And then acute cystitis is a symptomatic patients that present with dysuria, urgency, and then they also have a positive urine culture. And you want to consider that as a complication of a UTI. So both asymptomatic bacteriuria and acute cystitis are managed the same. So nitrofurantoin for 5 to 7 days, amoxicillin or amoxicillin clavulanic acid for 3 to 7 days, phosphomycin as a single dose, and then you want to avoid fluoroquinolones in all trimesters, and you want to avoid trimethoprim sulfamethoxazole within the first and the third trimester. And that's due to congenital malformations in the first trimester, and they also have an increased risk of kernicterus in the third trimester. So that's something to keep in mind. For acute pyelonephritis, these patients present with flank pain, nausea, vomiting, fever, or CVA angle tenderness, and they may or may not have cystitis symptoms. And treatment here would be to hospitalize and give them IV antibiotics, especially beta-lactams and meropenem. But you want to avoid aminoglycosides unless every other agent cannot be used. So that's last on the list, aminoglycosides. First, you want to give beta-lactams or meropenem. And you want to change to 10 to 14-day courses of oral antibiotics after they become afebrile for 24 hours. 40% of patients have an increased risk of bacteriuria. There's an increased risk of upper UTIs due to the progesterone-induced smooth muscle relaxation and dilation of the ureter. So when they dilate, you have more chances of it having a retrograde infection. The E. coli is going to be the most common cause at 70%, and a follow-up urine culture should have been done after a week to document resolution of the bacteriuria, just to see if it went away. Monthly urine cultures are recommended for the duration of the pregnancy to monitor for recurrent infections, and patients with persistent bacteriuria after more than 2 courses of therapy require daily suppressive therapy like nitrofurantoin. And for the duration of the pregnancy, UTI antibiotics in pregnancy are going to be recommended if they're nitrofurantoin, amoxicillin clavulanate, or cephalexin. The ones that are contraindicated, again, are your tetracyclines, fluoroquinolones, and TMP-SMX. Amoxicillin is appropriate first choice, but as some E. coli strains have been developing resistance, and antibiotics may be needed. They may need to be changed on the basis of whatever kind of culture sensitivity you get. And then postpartum urinary retention, risk factors here would be if the patient is a nulliparity, prolonged labor, if they have any type of perineal injury or regional analgesia, cesarean delivery, and instrumental vaginal delivery are all increase the risk of a postpartum urinary retention. Clinical features here would be an inability to void. There's a sensation of bladder fullness and dribbling of urine, or the small volume voids. And the management for postpartum urinary retention would be to give them analgesics, encourage them to walk around and ambulate, as well as urinary catheterization. Now, the normal bladder capacity is 350 to 400 milliliters, and normal post-void residual volumes is less than 150 milliliters in women. So an epidural anesthesia will then require urethral catheterization during labor due to a temporary loss of voluntary bladder function. Voiding resumes after a few hours of the anesthesia, but it may be delayed in some, so due to bladder overdistension as well as perineal swelling around the urethra. And then urethral catheterization is better than an ultrasound for diagnosis. and that's will give you a post-void residual volume of more than 150 milliliters, and that would be diagnostic. So if you have a post-void residual volume that's high, that's a diagnostic for diagnostic and indicative of urethral catheterizations. Then it can remain in place until urination is possible as the perineal edema goes away, and most patients regain bladder function after they do that intervention. And that is the complete end of